Let's go over the answers to the warm-up review. First question, which medication overdose is treated with sodium bicarbonate? So you use bicarb to alkalinize the urine, which is going to trap weak acids. So you give bicarb to treat overdose with weak acids, such as aspirin. Next, a patient presents with tinnitus, dizziness, headaches, and GI distress. So what drug is potentially causing these symptoms? Well, this syndrome is called synchonism, which is typically caused by either quinine or quinidine. And the last one, which testicular tumor is associated with each of the following statements? So composed of cytotrophoblasts and syncytiotrophoblasts is choriocarcinoma. May present initially with gynecomastia is Leydig cell tumors, or rarely you can get a Sertoli cell tumor that can cause this as well. Elevated AFP would be a yolk sac tumor primarily, but you also need to think about embryonal cell carcinoma. Elevated beta HCG is either choriocarcinoma or embryonal carcinoma. And finally, histologic appearance similar to chondrocytes with cytoplasmic clearing is a seminoma. Now let's get started with the lecture.
Hello, and welcome to our Step 1 video on Bacterial Basics. I'm Dr. Jennifer Schufer, and I'm an infectious disease specialist. I'll be giving some lectures in the microbiology course. In this lecture, and in the next few lectures, we'll be discussing bacteria. In this lecture, we'll discuss bacterial structures, staining, and genetics. Let's start with bacterial structures. This can be a tedious subject, but it's still important and fair game on your test. So let's start with the cell membrane. Now look at this image of two different bacteria. The gram-positive organism is on one side and the gram-negative on the other. The plasma membrane is at the bottom of each of the figures. The plasma membrane is composed of a phospholipid bilayer that helps regulate what goes in and out of the cell. Some substances can diffuse across the membrane, but charged molecules usually need a transport protein or a protein channel to traverse that membrane. If you look above the cell membrane, you'll notice that the two figures look very different. The gram-positive organism has a thick peptidoglycan layer, also referred to as a cell wall. A cell wall lends support to the cellular structure and can protect against osmotic changes. Peptidoglycan contains polysaccharide chains that are cross-linked by peptides. The peptidoglycan layer dictates how much crystal violet stain is taken up during the gram stain procedure. In bacteria with thick peptidoglycan layer, the crystal violet stain is taken up well. The bacterium appears purple under the microscope, and the bacterium is referred to as gram-positive. Bacteria with a thin peptidoglycan layer and an outer membrane are unable to retain that crystal violet during the decolorization phase, and instead they take up the counter stain and therefore appear pink under the microscope at the end of the gram stain procedure. These are called gram-negative bacteria. These structural differences do not merely impact our staining studies, but also determine other interactions between the bacteria and the host. Let me give you an example. The thick peptidoglycan layer of the gram-positive organisms contains lipoteichoic acids, but gram-negative organisms don't have these acids in their structure. The lipoteichoic acids in the cell wall induce cytokine production, which then sets off a number of reactions within the host. Just to remind you, acute phase cytokines include interleukin-1, interleukin-6, TNF-alpha. We'll talk more about cytokines in immunology, but I wanted to review those quickly. Now look at the other figure, the one of the gram-negative bacterium. What you will notice on the gram-negative figure, besides the very small peptidoglycan layer, is the presence of an outer membrane. This is a distinctive feature of the gram-negative bacteria. Again, this structural difference impacts how it interacts with the host. The outer membrane contains something called lipopolysaccharide, or LPS. LPS is an endotoxin. That's a potent stimulator of cytokines. So here we see that the gram-negative bacteria can stimulate the acute phase cytokines too. Gram-negatives do not use lipoteichoic acid like gram-positives, but rather the LPS contained within the outer membrane. The inflammatory reaction from LPS can result in septic shock, and it's a huge contributor to the morbidity and mortality seen in severe gram-negative infections. Let's continue to look at that figure of the gram-negative bacterium. The gram-negative organism has both an inner and an outer membrane. In between these two membranes is the periplasmic space. This periplasmic space is the location of many proteins, including beta-lactamases. What are beta-lactamases? These are enzymes that break down beta-lactam antibiotics like penicillins and cephalosporins. So gram-negative bacteria can carry around a resistance mechanism, a beta-lactamase enzyme, in their periplasmic space. Okay, let's look at the surface of the cell and talk about the fimbriae. These are hair-like structures that mediate adherence of bacteria to surfaces, including the surfaces of other cells. These fimbriae are what allow bacteria to colonize membranes throughout the body, like the respiratory tract or the GI tract. Now, similar to fimbriae are pili, or pilus in its singular form. The pilus forms an attachment between two bacteria during conjugation. And what is conjugation? Remember it like this. Conjugation describes a bacterial conjugal visit. A pilus allows transfer of DNA from one bacterium to another. These pili used during conjugation are sometimes called sex pili or F pili. And now flagella. Flagella are usually longer than fimbriae and pili. They're filamentous structures that whip around, providing mobility to bacteria. Now let's go through a few more bacterial structures. Let's stay on the surface of the cell and talk about glycocalyx. Glycocalyx literally means sugar coat. It refers to a gelatinous polysaccharide coating for bacteria. It aids in attachment to foreign material like indwelling catheters, as well as natural surfaces like teeth. If the glycocalyx is organized and firmly adherent to the bacterium, it's called a capsule. If it's loosely adherent with less organized structure, it's referred to as slime or biofilm. Let's take a second to talk about capsules. Not all bacteria have capsules, but many bacteria that cause significant human disease do. A capsule protects the bacterium against phagocytosis, allowing it to elude the immune system just a little longer than some other bacteria and giving it time to divide and therefore cause overwhelming infection. A capsule can be considered a virulence factor. A virulence factor is some characteristic of an infecting organism that makes it stronger or more virulent. So how can we tell if a bacterium has a capsule? Well, one way to tell is through the Quelling reaction. An anticapsular serum can be added to the bacteria. If there's a capsule, it becomes swollen, looking under a microscope, and this is called the Quelling reaction. One way to remember this is Quelling equals capsular swelling. So I want you to remember the Quelling reaction. But I'm also going to give you a list of some of the encapsulated organisms. A mnemonic you can use is even some pretty nasty killers have shiny bodies. This is to help you remember these organisms. E. coli, just some strains, but E. coli, Streptococcus pneumoniae, Pseudomonas aeruginosa, Neisseria meningitidis, Klebsiella pneumoniae, Haemophilus influenza type B, Salmonella typhi, group B strep. So even some pretty nasty killers have shiny bodies. Of that list, I think that 3 are especially important and are tested routinely. These are Streptococcus pneumoniae, Haemophilus influenzae, and Neisseria meningitidis. These can be remembered by the word SHIN. Strep pneumo, Haemophilus influenzae, and Neisseria meningitidis. These are big-time players. They can cause overwhelming sepsis and death in splenectomy patients who are unfortunate enough to be infected. But there are also effective vaccines against all 3 of these organisms. A splenic patient should always be vaccinated against these bacteria. The capsules of these bacteria, which serve as virulence factors for the bacteria, can also serve as antigens for vaccines. So Pneumovax, a pneumococcal vaccine, is derived from the capsular polysaccharide, as are vaccines against Neisseria meningitidis and Haemophilus influenzae. One other important fact regarding capsules, Cryptococcus neoformans, which is a yeast, also has a capsule. Cryptococcus causes meningitis in AIDS patients and has a capsule that can be easily identified using India ink stain. So when you think of encapsulated organisms, Cryptococcus should be high on that list, even though it's not a bacterium. All right, so just a second ago, I mentioned something called slime. Slime, or biofilm, is the polysaccharide that is produced by some bacteria and that can cover a surface of an entire microcolony of bacteria. When bacteria are under this covering, they're usually more resistant to antibiotics and more difficult to remove from surfaces. Okay, let's move inward from the surface of the bacterium and talk about some of the intracellular structures, starting from the ribosome. Ribosomes are where proteins are synthesized. 2 subunits fit together and work to translate mRNA. Bacteria are prokaryotes that have a 50S and a 30S subunit, which come together to make a 70S ribosome. Eukaryotes, like us, have a 60S and a 40S ribosome subunit that come together to make an 80S ribosome. The S refers to sedimentation coefficient. That is a measure of how rapidly these ribosomes sediment out in a solution. So don't spend too much time trying to get these numbers to add up. They don't. The reason I'm telling you this about the ribosomes of prokaryotes versus eukaryotes, though, is to highlight that they have different ribosomes. This structural difference provides a very useful target for antibiotics because we can preferentially target bacteria and not host cells. We'll talk about such antibiotics in another part of the course. Now, plasmids. Plasmids are pieces of genetic material that are separate from the chromosomal DNA. They replicate separately from the chromosomal DNA. Plasmids often contain genes that may be helpful to bacteria in certain situations, but that aren't essential for their survival. For example, plasmids can carry genes for antibiotic resistance or for toxin production. These plasmids are pieces of DNA that can be transferred from one bacterium to another during conjugation. So conjugation allows the transfer of resistance and virulence factors from one organism to another by way of plasmids. Okay, so besides conjugation, plasmids, what are some other mechanisms of genetic change in bacteria? Well, let's talk about 3 others. First, transformation. Transformation occurs when DNA is released from a lysed cell and is then taken up by a living bacterium. These DNA fragments can then be incorporated into the chromosomal DNA of the recipient bacterium, resulting in a recombinant bacterium. The recipient bacterium now has a recombination of its original chromosomal genes with those from the acquired DNA fragments. Transformation is only an option for a few species of bacteria. Interestingly, these include those Shin organisms that we just talked about a few minutes ago: Strep pneumo, Haemophilus influenzae, and Neisseria meningitidis. Now let's discuss transposons. These are small segments of DNA that can self-excise and then relocate to another place on the chromosome. They can also relocate to a different chromosome altogether or to a plasmid. Some transposons are very small and carry minimal information. Others can carry antibiotic resistance or virulence factors. So how do you think that transposons could be responsible for spreading antibiotic resistance? Well, if the transposon was relocated from a chromosome to a plasmid, you can see how that gene coding for antibiotic resistance could then be spread to other bacteria via conjugation. Lastly, let's discuss transduction. Transduction relies on something called bacteriophage, or just a phage. Phages are viruses that infect bacteria. The phage attaches to the bacterium, injects its DNA into the cell. More phage DNA and phage proteins are made and are repackaged into new viral capsids. These are then released when the bacteria ruptures. What's important to know here is that phage replication isn't a clean process. Some of the bacterial DNA can end up inside that viral capsid. So when that bacteriophage goes to inject its own DNA into the next bacterium, what it's actually injecting is both viral and bacterial DNA. The bacterial DNA can then be recombined with the DNA of the infected cell. Okay, that's about it for general structure and genetics of bacteria. Now let's talk about some bacteria that have unusual characteristics and how you identify these. There are 2 bacteria that I want you to remember because they have unusual cell membranes or walls. And the first is Mycoplasma species. Unlike most other bacteria, Mycoplasma requires sterols for their plasma membrane, and they have no cell wall. Why would that be important that they have no cell wall? Well, one reason is that many of our antibiotics target the cell wall. These would not be very useful against Mycoplasma. Another bacteria I want you to remember is Mycobacteria species. Mycobacteria have cell walls that contain mycolic acid and are rich in lipids, making them somewhat resistant to gram staining, but very resilient in a variety of environments. All right, we've been touching on this the whole lecture through, but let's focus on staining for a moment. As we already mentioned, gram staining divides most bacteria into one of 2 groups, gram-positives or gram-negatives. Gram-positive organisms stain blue or purple because they retain the crystal violet primary stain. Gram-negative bacteria are going to stain pink or red because they lose the crystal violet during decolorization and they retain the counter stain. Now, there are some bacteria that just don't gram stain very well, and I'll go through a few of the important ones right now. You'll recognize a couple of these. So mycobacteria. Remember that mycobacteria have an unusual cell wall with mycolic acids and high lipid content, and it causes irregular uptake of gram stain. And mycoplasma. Do you remember? We just talked about this. Remember, mycoplasma has no cell wall, which affects its staining. Treponema. Now, treponema are gram-negative organisms that are shaped like very tiny corkscrews, but they're difficult to visualize because of their size, and they can be seen better with dark field microscopy. Legionella pneumophila. Legionella stains poorly because of unusual branched chain fatty acids that they have in their cell wall. We've talked about some of the limitations of gram staining now, so let's talk about some other important stains that are used to identify bacteria. There's Giemsa stain. Giemsa can be used to stain Borrelia, Rickettsia, Chlamydia, Plasmodium, Trypanosomes, and Histoplasma. Then there's PAS, periodic acid shift stain. PAS stains glycogen and mucopolysaccharides. It can be used to diagnose Whipple's disease caused by Trophirima whippleyi. Zeal-Nielsen stain. The Zeal-Nielsen is used to stain acid-fast organisms like Mycobacterium tuberculosis. And India ink. We mentioned this when we were discussing capsules, but this stain, it isn't routinely used for bacteria, but it's important for fungus. And remember, this is for Cryptococcus neoformans. Now, silver stain. Silver stain is used for fungi, including Pneumocystis, and it can also be used for Legionella. And just so you know, being familiar with these few stains can really pay off for you on the test. Now it's time for your end of session quiz, so I want you to pause your video, go through those questions now, and then restart your video so we can go through them together. All right, first question. What bacterial structure has the following function? It mediates adherence of bacteria to the surface of a cell. That's the fimbriae. Protects against phagocytosis. That's capsule. Provides rigid support to the bacterial cell and protects against osmotic pressure differences. This describes the peptidoglycan layer of the cell wall. Space between the inner and outer cellular membranes in gram-negative bacteria. This is the periplasmic space. Motility. Motility is mediated by flagella. Bacterial form which provides resistance to dehydration, heat, and chemicals. This is a spore. Forms attachment between two bacteria during conjugation. This is the pilus, sometimes called the F pilus or the sex pilus. And independent pieces of genetic material within bacteria that may contain genes for antibiotic resistance. This describes a plasmid. Okay, next. What stain is required to see the following organism or substance? For Cryptococcus, you can use India ink. For PCP or Pneumocystis, you can use silver stain. For chlamydia, you can use a Giemsa stain. Next, which organisms are not well visualized with gram stain? Treponema. Remember that treponema have a thin corkscrew shape that's too thin to be well visualized with a gram stain. Legionella. Legionella's cell wall has unusual fatty acids that resist stain. Mycoplasma species like Mycoplasma pneumoniae, they have no cell wall, so they don't gram stain. And Mycobacteria, they have a high lipid content that resists gram staining. Next, which bacteria are encapsulated? The mnemonic to remember is even some pretty nasty killers have shiny bodies. So that's some strains of E. coli, Strep pneumoniae, Pseudomonas aeruginosa, Neisseria meningitidis, Klebsiella pneumoniae, Haemophilus influenzae, Salmonella typhi, and Group B strep. And then it's not a bacterium, but another important pathogen to remember that has a capsule is Cryptococcus neoformans, which is a fungus. And last question, by what method are plasmids exchanged between bacteria? This is called conjugation. And remember that this process utilizes a pilus. And that's it for our end of session quiz, and that's the end of our Bacterial Basics video. I'll see you again soon.
Let's go over the warm-up. First question, what's the antidote for each of the following substances? For acetaminophen, the antidote is N-acetylcysteine. For salicylates like aspirin, the antidote is to give sodium bicarbonate to alkalinize the urine. Remember, aspirin is a weak acid, so to trap an acid in the urine, you're going to alkalinize the urine. For amphetamine overdose, you want to acidify the urine by giving ammonium chloride, since amphetamines are weak bases. For anticholinesterases and organophosphates, the first line reversal agent is atropine, and then pralidoxime if the atropine doesn't work. Remember, pralidoxime regenerates acetylcholinesterase. And for the overdose of an antimuscarinic anticholinergic agent like atropine, the antidote is physostigmine, which is a cholinesterase inhibitor. So we treat atropine overdose with a cholinesterase inhibitor, and we treat cholinesterase inhibitor overdoses with atropine. Next, which testicular tumor is associated with each of the following statements? Histologically may have an alveolar or tubular appearance, sometimes with papillary convolutions. That's embryonal carcinoma. Composed of multiple tissue types is a teratoma. Histologic endodermal sinus structures called Schiller-Duval bodies is a yolk sac tumor. 25% have cytoplasmic rod-shaped crystalloids of Reinke, is a Leydig cell tumor. Antigen-producing and associated with precocious puberty is Leydig cell tumors or possibly Sertoli cell tumor. The last question, what organism is commonly implicated in balanitis? Well, balanitis is infection and inflammation of the glans penis, and the most common causative organism is Candida albicans. Now let's get started with the lecture.
Hi, I'm Dr. Shuford, and welcome to our Step 1 video on bacterial toxins. So today we're talking about toxins. Toxins are poisonous substances produced by microorganisms. Now, we're going to talk about two different kinds of toxins, endotoxin and exotoxins. Let's start with endotoxin. Endotoxin is found within the outer membrane of gram-negative bacteria. If you remember back to the last micro lecture, we talked about how the gram-negative bacteria have lipopolysaccharide as part of their outer membrane. The lipid portion of their lipopolysaccharide, called lipid A, is the part responsible for the toxic effects of endotoxin. So the lipid A is trapped within the gram-negative bacterial structure while the cell remains intact. But once that bacterium is lysed, the lipid A is released into the host and causes systemic symptoms. Endotoxin-related symptoms can be severe, even ending in septic shock and death. Let's talk about how this happens. Endotoxin can activate macrophages, which in turn produce cytokines including interleukin-1, interleukin-6, and TNF-alpha. Interleukin-1 and interleukin-6 and TNF all mediate fever, but TNF can also cause cell death and cachexia. Now, another substance released from macrophages in response to endotoxin is nitric oxide. Nitric oxide causes vasodilatation, which can result in hypotension and development of septic shock. I think that this highlights an interesting aspect of human immune response, and that's the immune response itself is responsible for many of the severe symptoms associated with infection, including septic shock. Okay, so what else does endotoxin do? Well, endotoxin activates the complement pathway, increasing levels of C3a and C5a. C3a can mediate the release of histamine, leading to vasodilation again and increased vascular permeability and resulting in hypotension and edema. C5a, on the other hand, affects neutrophil chemotaxis. And finally, endotoxin activates tissue factor, which will in turn activate the coagulation cascade. And this is why we see disseminated intravascular coagulation, or DIC, with gram-negative sepsis. You'll hear more about this in the hematology section, but I'll explain it here briefly. DIC occurs when microthrombi develop throughout the body, consuming platelets and coagulation factors in the process. And this depletion of platelets and coagulation factors can then lead to bleeding issues. So you see clotting and bleeding simultaneously. Okay, so we just talked about endotoxin. Endotoxin is the lipopolysaccharide component of the gram-negative outer membrane. So it's part of the bacterial cell itself. Now let's talk about exotoxins. Exotoxins are proteins that are produced by the bacteria and then released from the bacteria. Now, thankfully, not all bacteria produce exotoxins. I say thankfully because these proteins are usually extremely harmful to humans, and very little exotoxin can go a long way. Usually the exotoxin-producing bacteria are gram-positives that have either plasmids or bacteriophages that encode for these exotoxin proteins. Another important point about exotoxins is that they are antigenic. You can develop antibodies to exotoxin. For example, tetanus and diphtheria vaccines are both toxoid vaccines, where the desired response is antibody to the toxin. Okay, so now that we've talked about exotoxins generally, let's talk about a few specific exotoxin-producing bacteria. This is probably a 4-star topic, so I really want you to concentrate here. Exotoxins come in several main types. Let me first mention neurotoxin, which is a toxin that interferes with neural transmission. Can you think of a couple toxins that would do this? The two that come to my mind are botulinum toxin and tetanus toxin. There are also enterotoxins. Enterotoxins affect the intestine, so these would include toxins produced by Shigella and Vibrio cholerae. I also want to mention the concept of superantigens. Superantigens are those exotoxins that are able to bind both an MHC2 receptor and a T cell receptor simultaneously. And this cross-linkage of the MHC2 receptor and a T cell receptor through one exotoxin allows for polyclonal expansion of T cells, causing a massive immune response and release of large amounts of cytokines. Remembering what we talked about just a few minutes ago regarding the host response to cytokine release, you can probably imagine how damaging an uncontrolled release of cytokines within the body can be. The two best known superantigen producers are Staphylococcus aureus and Streptococcus pyogenes, or group A strep. Go ahead and take a look at your study guide. What known toxins are secreted by Staph aureus and what's the action of each? So Staph aureus produces a variety of exotoxins. Let's talk about a few of them. There are 4 hemolysins: alpha, beta, gamma, and delta. Alpha hemolysin, also known as alpha toxin; beta hemolysin, also known as sphingomyelinase C; gamma hemolysin is a bicomponent protein that's both a leukocidin, that is, it's toxic to leukocytes, as well as a hemolysin, and that is that it lyses red blood cells. And delta hemolysin, also known as delta toxin, is toxic to erythrocytes as well as other cells. Another important toxin I want you to remember is panton-valentine leukocidin. It's responsible for a lot of the tissue destruction that we see with community-associated MRSA, or methicillin-resistant Staphylococcus aureus. It too is a bicomponent toxin like gamma hemolysin. Panton-valentine leukocidin affects both neutrophils and macrophages. Okay, so now let's talk about 2 superantigens produced by Staph aureus, the enterotoxins and TSST1. The enterotoxins have the ability to cause gastroenteritis. The term enterotoxin literally means toxic to the enteric system, so it shouldn't surprise you that it's associated with vomiting and diarrhea. The initial enterotoxins identified were called enterotoxin A through E, but many others have now been identified and described. TSST, or toxic shock syndrome toxin 1, is the toxin associated with toxic shock syndrome. Toxic shock syndrome presents with high fever, low blood pressure, and a diffuse rash that looks like a sunburn. A common test question on toxic shock syndrome will include a young woman that's just been on her menstrual cycle and left a superabsorbent tampon in place for a long time, and who's now experiencing fever, hypotension, and rash. So if you see this clinical scenario, think Staph aureus and toxic shock syndrome toxin 1. And the last type of staph toxin that I will mention is exfoliative toxin, which causes scalded skin syndrome in newborns. The toxins act at the zona granulosa in the epidermis, which results in flaccid bullae. This can involve large amounts of skin, sometimes almost the entire epidermis. This is usually seen in babies in their first week of life. Okay, moving on to Streptococcus pyogenes, also known as group A streptococcus. Look at the next question in your study guide as we go through this. What are the toxins for strep pyogenes? There's streptolysin O, which causes hemolysis on blood agar plates. Streptolysin O is oxygen labile. Remember O for oxygen labile. You might recognize the exotoxin streptolysin O because we use antibodies to streptolysin O to detect when a person has had an infection with group A strep. We can order ASO titers in order to check the serum levels of anti-streptolysin O antibodies. There's also streptolysin S. Streptolysin S is oxygen stable, so remember S for stable. There are also streptococcal pyrogenic exotoxins type A, B, and C. They are also known as erythrogenic toxins. These act as superantigens and are associated with a red rash and fever of scarlet fever. They've also been associated with streptococcal toxic shock syndrome, which is like the toxic shock syndrome that we just discussed with Staph aureus, but it's associated with a streptococcal infection rather than with Staphylococcus. Let's talk about some other bacteria that produce exotoxins. So Corynebacterium diphtheriae produces diphtheria toxin, which inactivates elongation factor 2, or EF2. Its effects include pharyngitis and this grayish pseudomembrane in the throat. Diphtheria toxin inhibits protein synthesis and is very potent. Cardiac and nerve cells are particularly vulnerable to damage from the toxin. The toxin can be lethal in very small quantities. Now for Pseudomonas aeruginosa. Pseudomonas aeruginosa is a particularly nasty bug. One of its virulence factors is exotoxin A. Exotoxin A also targets elongation factor just like diphtheria toxin does, thereby causing cell death. Now, I know that we cover Shigella in the gram-negative bacteria section, but let's talk about its toxin here. Shigella produces Shiga toxin. This toxin is very similar to the toxin that E. coli 0157H7 makes, which we'll be talking about momentarily. Both of these cleave host rRNA at the adenine base of the 60S ribosomal subunit, inhibiting protein synthesis and causing eventual cell death. Okay, now let's talk about E. coli. E. coli is found in huge numbers in the human intestinal tract. Most don't cause disease, but there are several different pathogenic types of E. coli that can cause human disease. I want to mention two toxin-forming types right now. One is called enterohemorrhagic E. coli, or EHEC E. coli. E. coli 0157H7 is one serotype of EHEC. Enterohemorrhagic E. coli forms a toxin called virocytotoxin, more commonly referred to as Shiga toxin. This toxin causes bloody diarrhea, and thus the name enterohemorrhagic E. coli. But it can also cause damage to renal and endothelial cells, resulting in hemolytic uremic syndrome that this organism is particularly known for. What is HUS? Do you remember the three major findings? For HUS, be sure to remember hemolytic anemia, thrombocytopenia, and acute renal failure. The other type of toxin-producing E. coli I want to discuss is enterotoxigenic E. coli, or ETEC. This type of E. coli can produce one of two toxins. The heat labile toxin stimulates adenylyl cyclase, causing an increase in cyclic AMP. The heat stable toxin stimulates guanylyl cyclase, increasing cyclic GMP. Either way, you get watery diarrhea that's similar in character to cholera, actually. Enterotoxigenic E. coli is the leading cause of traveler's diarrhea, also known by a variety of titles such as Montezuma's Revenge, Delhi Belly, among others. All right, let's move on to Yersinia enterocolitica. This also produces a heat-stable toxin, which is very similar to the enterotoxigenic E. coli heat-stable toxin. Like E. coli's, Yersinia's exotoxin also activates guanylyl cyclase, increasing cyclic GMP. Yersinia infection can cause abdominal pain that's sometimes misdiagnosed as appendicitis, leading to the title pseudoappendicitis. Okay, Bacillus anthracis. Now, this is an organism that causes anthrax. Bacillus anthracis produces anthrax toxin with three components. These components are edema factor, lethal factor, and protective antigen. What I want you to remember is that edema factor is adenylyl cyclase, which increases cyclic AMP and causes edema. Now, Vibrio cholerae. It utilizes a similar mechanism through choleragen, or cholera toxin. Cholera toxin stimulates adenylyl cyclase, increasing cyclic AMP. This causes chloride and water to cross into the lumen of the intestines, creating large amounts of rice water stools that are typical of cholera. A person can lose 12 to 20 liters of fluid in a day, leading to circulatory collapse. And this is why rehydration is such an important part of therapy. It's really life-saving in many people. All right, now Bordetella pertussis. Bordetella pertussis causes pertussis and uses a different mechanism to accomplish a rise in cyclic AMP. Bordetella pertussis makes pertussis toxin, which binds to inhibitory G proteins and inactivates them. By blocking the activity of the inhibitor, there's an increase in cyclic AMP. Do you see a pattern here? Again, we're seeing this rise in cyclic AMP, and as you might expect, the structure of pertussis toxin is similar to the other bacterial toxins that we've talked about that also increase cyclic AMP. Okay, let's move on to Clostridium. Let's talk about a few toxigenic species. First, Clostridium tetani, which causes tetanus. The tetanus toxin responsible for the clinical manifestations of tetanus is tetanospasm. Tetanospasm blocks the release of the inhibitory neurotransmitters GABA and glycine. Without these inhibitors, motor neurons are firing unopposed and create persistent muscle contraction. This leads to lockjaw and other muscle spasm findings that are so characteristic of tetanus. Now for Clostridium botulinum, which is the etiologic agent of botulism. Clostridium botulinum actually produces several distinct exotoxins, currently labeled A through G. These all act at the neuromuscular junction and inhibit the release of acetylcholine. And when this happens, you get flaccid paralysis. This might show up on your test as a question about flaccid paralysis following consumption of spoiled canned goods. In these cases, the botulinum toxin is preformed in the canned food and the person ingests the toxin. You should also remember that children under 1 year of age should not eat honey because of the risk of botulism. In this case, the Clostridium botulinum spores are in the honey and they can germinate in the intestine of the infant, colonizing the colon and forming the toxin in vivo. Interestingly, botulinum toxin is now being used widely for therapeutic purposes, like to treat strabismus and blepharospasm, and it's also very commonly used for cosmetic purposes. So to quickly review, Clostridium tetanus releases the exotoxin tetanospasm that causes spastic paralysis by blocking release of inhibitory neurotransmitters GABA and glycine. Clostridium botulinum releases botulinum toxin that causes flaccid paralysis by blocking acetylcholine release at the neuromuscular junction. Now for one last Clostridium species, let's talk about Clostridium perfringens. Clostridium perfringens can produce alpha toxin, a phospholipase that causes gas, gangrene, and myonecrosis. Clostridium perfringens can also make an enterotoxin that's responsible for a large number of food poisoning cases. The enterotoxin is produced when food is left out too long after being cooked. The spores that can withstand that cooking process have a chance to germinate and produce the enterotoxin if it's left out for too long after cooking is complete. Just one more concept to cover before we end. Let's talk about the bacterial growth curve. I think this one will be pretty simple for you. Imagine that you have a pure culture of some bacteria and you inoculate a few of them into a liquid growth medium. Now, starting from the left, you initially have a little bit of a lag phase where the bacteria are adjusting and gearing up for cell division. Then the bacteria enter their log phase or exponential growth phase. And at this point, there are few bacteria with plenty of nutrients, so they're dividing like crazy. And interestingly, this is the phase in which they're very vulnerable to our interventions like antibiotics and radiation. Now, as the number of bacteria increase, the nutrients become depleted and the toxins begin to accumulate. And the bacteria just don't have the resources to divide quickly. So at this point, they slow their metabolism and their cell division, and this is the stationary phase. They're just kind of hanging out at this point. Some will form spores at this stage to protect themselves from an inhospitable environment, but eventually the death rate does exceed the rate of division, leading to the death phase where you see the curve trend downwards. Okay, now let's move on to the end of session quiz. So go ahead and turn off your video, answer the end of session quiz questions, and then restart the video so that we can go through the answers together. All right, first question. What exotoxin matches the following characteristics? Inhibits acetylcholine release at the neuromuscular junction, resulting in flaccid paralysis. This is botulinum toxin. Phospholipase that causes gas gangrene. This is the alpha toxin of Clostridium perfringens. Inhibits the inhibitor of adenylyl cyclase, causing whooping cough. This is pertussis toxin. Stimulates adenylyl cyclase, resulting in chloride and water entering the intestinal lumen and causing diarrhea. This describes both the cholera toxin and the heat labile toxin produced by enterotoxigenic E. coli. Destroys leukocytes. This describes a leukocidin. Staph aureus has gamma hemolysin and Panton valentine leukocidin, both of which are bicomponent toxins that are toxic to leukocytes. Composed of edema factor, lethal factor, and protective antigen. This is anthrax toxin that's formed by Bacillus anthracis. Enterotoxin causing rice water diarrhea. Again, this is cholera toxin, and again, that heat labile E. coli toxin. Remember the term rice water diarrhea for cholera. Causes scarlet fever. This is due to the pyrogenic toxins of Strep pyogenes. Causes toxic shock syndrome. The one I want you to remember is TSST1 that's produced by Staph aureus. Inactivates EF2, causing pseudomembranous pharyngitis. This is diphtheria toxin. Blocks the release of inhibitory neurotransmitter glycine. This describes tetanospasmin. That's the tetanus toxin. And next, list 7 bacteria that we just talked about that secrete enterotoxins. We mentioned Vibrio cholerae, and we mentioned enterotoxigenic E. coli, making that heat labile toxin that causes similar diarrhea to cholera. We also mentioned that Staph aureus has a series of enterotoxins. We mentioned Shigella, Yersinia, and certain Clostridium species, specifically Clostridium difficile and also Clostridium perfringens. And that's the end of our lecture on bacterial toxins. I'll see you again soon.
So I grabbed that old critter by the scruff of his neck and I said, "Mr. Squirrel, you are a rascal. You are a rascal." You know, that story always reminds me, I don't know why, but it always reminds me of the major toxins produced by group A strep. You remember what they are? You've got your streptolysin S toxin, which is oxygen stable. You've got your streptolysin O, which is oxygen labile. And you've got your erythrogenic and pyogenic toxins that cause scarlet fever. But don't get that mixed up with acute rheumatic fever. That's a result of group A strep infection too, but that's antibody mediated, not toxin mediated. And rheumatic fever occurs a couple of weeks after the infection. Would you look at the time? I get to talking and before you know it, time's up. Well, from all of us here, I'd like to wish you happy studying and God bless, my friend.
Let's go over the answers to the warm-up. First question, what's the clinical use of clomiphene and how does it work?
Clomiphene is used for infertility, and it's an estrogen receptor antagonist in the hypothalamus that blocks normal feedback inhibition. This induces FSH secretion and stimulates follicles.
Next, what drugs inhibit prolactin secretion? These are the dopamine analogs like bromocriptine. And the last one, what are the signs and symptoms of anticholinergic activity? So you're dry as a bone, so you have decreased secretions and decreased salivation. You're hot as a hare, which is increased temperature. Red as a beet is peripheral vasodilation. Blind as a bat is mydriasis and cycloplegia. Mad as a hatter is agitation and delirium. And then bloated as a toad is constipation and urinary retention. Now let's move on to the lecture.
Hello, and welcome to our Step 1 video on Staphylococcus. Before we talk about Staphylococcus in particular, I want to go through this algorithm with you. This is a really good graphic that includes a lot of important information. Now, this is the gram-positive algorithm. Do you remember our discussion about gram staining? Some organisms stain very well with the crystal violet stain and retain that stain through the decolorization process. These organisms are called gram-positive. They stain bluish purple. So if you see a blue organism on an image, remember that that's a gram-positive organism. Now, what happens when you gram stain in the gram-negative organisms? Remember that they don't retain that crystal violet stain through that decolorization phase. These then get stained with a counter stain, and these organisms will look red or pink. So if you see an image of a pink bacteria, those are gram-negative. So I want you to look at this algorithm. Under the title gram-positive algorithm, you'll see the division between cocci, rods, and branching filaments. Cocci are spherical, rods are rod-shaped, and they're called bacilli. The branching filaments look a bit like fungus under a microscope because of the filaments. These different shapes are usually pretty easy to differentiate in the lab. Let's follow the cocci down that algorithm. Now, when we're talking about gram-positive cocci, we're usually talking about Staphylococcus or Streptococcus. So a good first step is to decide if this gram-positive coccus is strep or staph. One way to differentiate these two is by the organization of the bacteria underneath the microscope. So if the cocci stick together in clusters, you're usually dealing with a Staphylococcus. If the cocci are in pairs or in chains, then you're usually dealing with a strep species. This characteristic is very important, so I definitely want you to remember that clusters mean staph and pairs and chains mean strep. But bacterial appearances can be deceiving, so we can do other biochemical tests to differentiate them as well. We do this by looking for catalase. Let's talk about catalase. Catalase degrades hydrogen peroxide into oxygen and water. Hydrogen peroxide is itself toxic to bacteria, and hydrogen peroxide is used as a substrate for creation of the toxic hypochlorous acid through the action of myeloperoxidase. So degradation of the hydrogen peroxide supply by bacterial catalase can decrease the killing effect of the neutrophils and monocytes on those bacteria. I want to take a second to remind you about the link between catalase-producing organisms and chronic granulomatous disease. People with chronic granulomatous disease have NADPH oxidase deficiency. Phagocyte NADPH oxidase is used to reduce oxygen to reactive oxygen species, an early step in the formation of hydrogen peroxide and hypochlorous acid. If the host cell cannot form reactive oxygen species, then the small amount of hydrogen peroxide present in the environment will be easily broken down by the catalase by catalase-positive organisms. This lack of phagocyte NADPH oxidase leaves these patients very susceptible to infections by catalase-producing organisms. Okay, so back to catalase. If you put a drop of hydrogen peroxide on staph, which has catalase, you're going to see the formation of gas bubbles. This is the oxygen. If you put the hydrogen peroxide on strep, you're going to see no reaction. This is because strep doesn't have catalase, and so it can't break down the hydrogen peroxide into oxygen and water. Okay. So what if you know that your gram-positive coccus is a Staphylococcus? You'll probably want to know whether the organism is a highly virulent Staph aureus or if it's one of the typically less virulent species of Staphylococcus. The coagulase test separates out Staph aureus from most other Staph species. Staph aureus is coagulase positive And several other species like Staphylococcus epidermidis and Staphylococcus saprophyticus are coagulase negative. Now, coagulase production is not merely a way to differentiate the staph species, but it's an important virulence factor for the staph species that possess it. Coagulase allows bacteria to induce coagulation or blood clotting. It also allows bacterial binding to fibrin and fibrinogen, increasing binding to host tissues and decreasing phagocytosis. So the coagulase negative staph that I want you to remember are Staph epidermidis and Staph saprophyticus. As you can see in your algorithm, these can be differentiated by the novobiocin sensitivity test. Staph epidermidis is, not surprisingly, all over your skin, your epidermis. It frequently is a blood culture contaminant, but it can also cause infection on things like prosthetic heart valves and other implanted material. And Staph saprophyticus is a common cause of urinary tract infection. You can see that we've made it all the way down the staph pathway. I'm glad we did that because staph is super, super important. Now I want us to talk about strep. So let's review for a moment. Remember that we're talking about gram-positive organisms, and these are going to look blue or purple on gram stain. Now we're also talking about cocci or spherical organisms, but now we're going to talk about the catalase negative organisms. What are these going to look like? Well, instead of cocci in clusters like we see with staph, we're going to see cocci in chains. Sometimes this chain is just a chain of 2 cocci and it'll be called cocci in pairs. Other times it'll be longer chains. For the catalase negative bacteria, the microbiology lab will frequently provide a description of the bacteria's ability to hemolyze blood agar. If there is complete hemolysis of the blood agar, there will be a clear ring around the bacterial colony, and this is called beta hemolysis. 2 types of strep usually cause beta hemolysis, group A strep and group B strep. Group A strep, also known as strep pyogenes, causes strep throat. Group B strep, also known as strep agalactiae, can colonize the female genital tract and cause pneumonia and meningitis in newborns. So we test pregnant women for group B strep at the end of pregnancy. Now, if you get partial hemolysis, you'll see a little green circle around the colony, and this is called alpha hemolysis. I want you to think of 2 types of strep when you see alpha hemolysis. One is strep viridans and the other is strep pneumoniae. Now, viridans actually means green and refers to that green alpha hemolysis that you see in strep viridans. Strep viridans is a colonizer of the oral cavity and can cause infective endocarditis in patients that have poor dentition or after dental procedures. Strep pneumoniae can cause pneumonia and meningitis. It is certainly known to show up on tests, so be sure that you know about it. It's usually described as gram-positive diplococci. So if you see that description, think strep pneumoniae. Another differentiating characteristic, and one that we've talked about in previous lectures, is that strep pneumo has a capsule. So if you see a streptococcus with alpha hemolysis and a capsule, think strep pneumo. And if it has alpha hemolysis without a capsule, think strep viridans. And finally, there is gamma hemolysis, and this occurs when there's no hemolysis. So there's no little ring of any kind of discoloration around that bacterial colony, and this is typical of Enterococcus. So a catalase negative gram-positive coccus without hemolysis on blood agar is likely Enterococcus. Okay, looking at the middle division, we see the gram-positive rods or gram-positive bacilli. Look at the gram-positive rods that we've listed. First is Clostridium. Clostridium is anaerobic. So if you see an anaerobic gram-positive rod on your test, think Clostridium. Corynebacterium, Listeria, and Bacillus are all on that list as well. Remember that Listeria is linked to contaminated deli meat and it causes meningitis in the very young and the very old. And lastly, there's Mycobacterium. The place where they will mention mycobacteria is usually not in reference to a gram stain, though. It's usually in reference to acid-fast staining. They'll mention acid-fast bacilli on a sputum sample, and you should think of Mycobacterium tuberculosis. The last section on that algorithm are some gram-positive bacteria that are neither cocci nor rods. They're referred to as branching filaments. These have a similar appearance to some fungi. The 2 that you need to remember are Actinomyces and Nocardia. Actinomyces is an anaerobe and Nocardia is an aerobe. Okay, now I want you to look at your study guide. There's a blank algorithm for you. We've also provided a blank PDF of the algorithm on your video viewer so that you can print that out and practice. I want you to spend some time filling this out and reviewing it. It's not difficult, but it just requires a little bit of repetition. Now let's focus our attention on just one bacterium, Staph aureus. Staph aureus is a particularly virulent organism, a really, really nasty gram-positive coccus that causes a whole host of human illnesses. Staph aureus has been getting a lot of press in recent years because of its resistance profile. MRSA is a common household topic these days. MRSA, or methicillin-resistant Staph aureus, is a Staph aureus that's resistant to an anti-staphylococcal penicillin derivative called methicillin. When it's resistant to methicillin, it usually is resistant to other antibiotics as well, and that's why it's important. Anyway, this bacterium used to be more of a hospital-associated organism, but now there's a type that circulates in the community. It causes a lot of skin infections, including rapidly worsening skin abscesses that frequently require surgical debridement. But whether or not the Staph aureus is methicillin resistant, the organism has a lot of virulence factors, and it's a major cause of morbidity and mortality in humans. It's a cause of skin infections, pneumonia, endocarditis, bloodstream infections, bone and joint infections, among others. One thing that we mentioned in an earlier lecture is Staph aureus' ability to produce toxins. The toxin production is responsible for toxic shock syndrome and scalded skin syndrome, as well as gastroenteritis. Let's talk about the gastroenteritis that's associated with Staph aureus real quick, since it's a frequent topic on tests. Staph aureus can grow in prepared foods, especially ones with dairy or mayonnaise or eggs in it. Often the question will mention potato salad or mayonnaise by name. What happens is that the Staph aureus replicates and produces the enterotoxin while it's in the food. The symptoms of food poisoning result from ingestion of the preformed toxin that's already in the food. The hallmark of toxin ingestion is that vomiting occurs really rapidly after the ingestion of that contaminated food, and then it resolves pretty quickly too. So that's food poisoning from preformed toxins, and you should definitely think about Staph aureus. The other bacteria that may come to mind here is Bacillus cereus, which also causes vomiting within a few hours of ingesting and then resolves within 24 hours. The big difference is the food that they're associated with. If you see the words fried rice or reheated rice in the question, then they're going to be looking for Bacillus cereus, preformed toxin. If they mention mayonnaise or potato salad, the answer is Staph aureus, preformed toxin. Now, I want to mention one other virulence factor with Staph aureus. Staph aureus can make protein A, which can bind to human immunoglobulin. When it does so, it disrupts opsonization and phagocytosis, allowing increased survival of Staph aureus. That is one of many virulence factors of Staph aureus, contributing to its success at causing human illness. So at this point, I would like to briefly mention some pigment-producing bacteria. Staph aureus happens to be one of them, so this just seems like a good place to fit that topic into our discussion. Staph aureus forms large golden colonies. That's the name aureus, which refers to this gold color. Remember that AU is the chemical symbol for gold, and Staph aureus has golden pigment. Actinomyces israelii is another pigmented bacterium. It causes yellow granules, also known as sulfur granules, that can exude from the infected site. These yellow granules are actually colonies of the pigmented bacteria surrounded by neutrophils. One way that some students remember this pigmented bacterium is that Israel has yellow sand. That reminds you of that granular exudate and the color of the granules. Another well-known and well-tested pigmented bacterium is Pseudomonas aeruginosa. It has a blue-green pigment. And one way to remember this fact is to remember that arugula is green. That's a decent mnemonic, but it may be more helpful to you, for you to remember that Pseudomonas is an organism that's associated with water and air. When you think of water and air, think of the colors blue and green. Pseudomonas loves moist environments, which is why it causes hot tub folliculitis and infections in burn patients. It's also found in sweaty sneakers, all these moist places. Lastly, remember that Serratia marcescens has a red pigment. You can think of a maraschino cherry for that one, or you can think of Mars, which is the red planet. Okay, now let's keep moving through the Staphylococci. Specifically, let's talk about coagulase-negative Staphylococci. First, let's mention Staph epidermidis. Staph epidermidis is a skin colonizer. It's all over your skin. It's supposed to be there, and it usually doesn't cause any problems. Where you see Staph epidermidis causing problems and when it gains access into the bloodstream and comes into contact with foreign material like prosthetic heart valves and central venous catheters and prosthetic joints. Staph epidermidis can cause biofilm and require removal of that prosthesis to actually achieve cure. And finally, let's talk about Staph saprophyticus. We've already briefly mentioned the disease that it's usually associated with. Do you remember that? That's right, it's UTIs. It's implicated in about 10 to 20% of UTIs in females, being most prevalent among young sexually active females. You probably won't hear much else about Staph saprophyticus except that UTI connection. And that completes our discussion of Staphylococcus. Now I want you to pause your video and work your way through those end of session questions. When you've finished, turn your video back on and we'll go through the end of session quiz questions together. All right, let's go through those answers to the end of session quiz. The first question, label the following gram-positive algorithm. Here's the chart, so pause your video if you need to and you can check your answers. Next question, what is the function of catalase? It degrades hydrogen peroxide into water and oxygen. Next, 1 hour after eating potato salad at a picnic, an entire family begins to vomit. After about 10 hours, they were better. What is the organism? This is Staph aureus. Remember that classic association with Staph aureus and prepared foods, especially ones with dairy, mayonnaise, or eggs in them. But you should also remember that Bacillus cereus is on that differential too, but it's usually associated with fried rice or reheated rice dishes. And the last question, what very common aerobic skin colonizer is responsible for many indwelling foreign device infections? The one I want you to remember is Staphylococcus epidermidis. And that's it for our video on Staphylococcus. I'll see you next time.
It's time for another 3-question warm-up. Let's get going. Which medication overdose can be treated with ammonium chloride? So ammonium chloride, that's going to acidify the urine. It's going to trap weak bases. So this is for treating overdoses of drugs that are weak bases. Things like amphetamines are examples. Next, what are the target cells of LH, luteinizing hormone? Well, LH is going to stimulate theca cells in females, but then it's also going to target the Leydig cells in males. Next question, what ovarian tumor matches each of the following statements? So first we have estrogen secreting precocious puberty. Think of a granulosa theca cell tumor. Next, produces AFP or alpha fetoprotein. Think of a yolk sac tumor, also referred to as an endodermal sinus tumor. Next, we have Samoma bodies. Think of a serous cyst adenocarcinoma. And then we have a testosterone secreting, also leading to virilization. Think of a Sertoli-Leydig cell tumor. All right, that's it for the warm-up. Let's get to that lecture now.
Hello again, and welcome to our Step 1 video on Streptococcus. In our last video, we looked at the gram-positive algorithm and then talked about Staphylococcus in some detail. In this lecture, we're going to cover Streptococcus. First, I want to go over the algorithm again, concentrating on the Streptococcus information. So, first, what's the focus of this algorithm? Remember, this is covering gram-positive organisms. That is, the bacteria that stain bluish-purple on gram stain. Now, let's specifically look at the gram-positive cocci. Do you remember how we differentiate the staph from the strep? Remember that we look for catalase. Staph is catalase positive and strep is catalase negative. Then what do we do to differentiate the various types of streptococci? Remember that this is when we look at the blood agar plates to see how the streptococci are interacting with those blood cells. There's alpha, beta, and gamma hemolysis. Alpha hemolysis is partial hemolysis that results in a green ring around the bacterial colonies. Streptococcus pneumoniae and Viridans streptococcus both exhibit alpha hemolysis. Now, beta hemolysis is complete hemolysis, and it's seen as a clear zone around the colony. Group A strep, also known as strep pyogenes, demonstrates beta hemolysis. This can be confusing. Don't think that the A in Group A strep indicates alpha hemolysis. It does not. Group A strep exhibits beta hemolysis. Group B strep, or strep agalactiae, also exhibits beta hemolysis. Finally, there's gamma hemolysis, where there's no evidence of hemolysis. Enterococcus usually exhibits gamma hemolysis, as does Streptococcus bovis. Okay, let's talk about one of the Streptococcus species that you definitely need to know about, and that's Streptococcus pneumoniae. You will also hear this referred to as strep pneumo or as pneumococcus. Strep pneumo appears as gram-positive diplococci. If you see that description, gram-positive diplococci in sputum, blood cultures, or CSF, you need to think about strep pneumo. In adults, strep pneumo is the most common cause of community-acquired pneumonia and bacterial meningitis, and it's one of the most common causes of otitis media and sinusitis. When describing pneumococcal pneumonia on a test, they will talk about a sudden onset of chills, lobar consolidation, and rust-colored sputum. Another thing I want you to remember is that splenectomy patients can have fulminant septicemia with strep pneumo. Remember talking about how encapsulated organisms are troublesome for asplenic patients? Well, strep pneumo definitely has a capsule. Do you remember the other important encapsulated organisms we talked about? You need to remember strep pneumo, Haemophilus influenzae, and Neisseria meningitidis. The great news about strep pneumo is that there are vaccines available for children and for adults. There are currently 2 available vaccines recommended in the United States, the pneumococcal conjugate vaccine, PCV13, and the pneumococcal polysaccharide vaccine, PPSV23. The PCV13 is the one typically given to all infants. Current recommendations say that adults who meet criteria for vaccination should get both the PCV13 and the PPSV23 vaccines spread out over time. There are a lot of indications for giving the pneumococcal vaccines to adults, and I'm going to quickly mention a few of them here. Anyone over 65, or that should be 65 and over. Anyone 2 to 64 who has chronic illness like heart disease, lung disease, sickle cell disease, diabetes, or cirrhosis. Anyone who has disease that lowers the immune system, something like leukemia, lymphoma, kidney failure, HIV, or asplenia. Anyone who takes medicines that reduce immune response, like steroids, chemotherapy, or radiation therapy. And anyone who smokes or has asthma. As you can see, a huge portion of the population actually qualifies for pneumococcal vaccine, so keep that in mind. As for virulence factors, I think the most important for you to remember is that capsule. Another strep pneumo virulence factor to remember is an IgA protease. IgA is the immunoglobulin that helps protect mucosal surfaces from bacterial infection. Well, an IgA protease can cleave IgA, which would help create a survival advantage for bacteria colonizing on a mucosal surface. All right, now we're going to keep talking about alpha hemolytic strep, but move from strep pneumo to viridian strep. Remember that alpha hemolysis leaves that greenish ring around the colony on the blood agar. So viridian strep and strep pneumo will both exhibit alpha hemolysis. Now, I don't want you to get confused. Strep pneumo is the name of a single species, but viridian streptococci are a mixture of streptococcal species that usually exhibit alpha hemolysis. They're often classified into a number of different groups. I'm going to mention 5 groups of viridian streptococci so that you will at least have heard of these groups, but I don't think that you need to memorize them right now. There's a strep mutans group, strep salivarius group, strep aeruginosus group, strep mitis group, and strep sanguinis group. Sometimes the strep bovis group is included among the viridian streptococci, but we're going to talk about these streptococci separately. Viridian streptococci are considered normal flora, meaning they normally grow on mucosal surfaces of the oropharynx and the GI tract, and they typically cause few problems when they stay on the mucosal surface. When they inhabit dental plaque on the surface of a tooth, especially Streptococcus mutans, they can destroy the surface of the tooth, resulting in dental caries. When they get into the bloodstream, especially Streptococcus sanguinis, they can cause subacute infective endocarditis. So viridian strep are abundant in the oral cavity, usually causing no particular problem at all, but threatening to cause dental caries and to get into the bloodstream. And how do you think these bacteria would get from the oropharynx into the bloodstream? Well, one way is through just brushing your teeth, but another way is through dental procedures, and one that we hear more about. And not surprisingly, that's what kind of happens every day, occasionally ending in infective endocarditis. However, the point I want to emphasize is that this doesn't usually happen to people that have normal heart valves. The heart valves that become infected during an episode of bacteremia are those that have been previously damaged, especially ones that have had endocarditis before and prosthetic heart valves. Without some major pre-existing abnormality, that circulating viridian streptococcus species aren't usually going to be a problem. But when abnormalities are already present on or around the heart valve, we need to consider giving antibacterial prophylaxis just prior to dental procedures to prevent infective endocarditis. The favored antibiotic in this situation is a large dose of amoxicillin. Okay, now let's move on to a favorite topic for tests. Family members, neighbors, everyone wants to know about this. I'm talking about group A strep, also known as strep pyogenes. So group A strep is a pretty virulent organism. It can cause typical infections like strep throat, but it can also throw some curveballs at you like toxin-mediated illnesses and immunologic events. And so this is a good one to know well. Okay, let's look in the study guide. What human disease can be caused by strep pyogenes or group A strep? The first thing that comes to mind is probably one of the more common infections like acute pharyngitis, also known as strep throat. Group A strep can also cause cellulitis. Invasive infections include group A strep bacteremia and pneumonia. Now let's move on to immunologic illnesses associated with group A strep. This group includes acute post-streptococcal glomerulonephritis as well as rheumatic fever. Rheumatic fever is an uncommon complication of strep pharyngitis that probably results from molecular mimicry. That is, the immune system attacks host cells because the cell's antigens resemble that of the bacteria. Post-streptococcal glomerulonephritis occurs after either an episode of strep throat or a skin infection. It occurs when immune complexes are deposited in the glomerulus. No one knows why this happens in some people, but it likely results from streptococcal antigens being deposited in the glomeruli, which then induces an immune response there. The last category of diseases resulting from group A strep is the toxin-mediated diseases, and this includes streptococcal toxic shock syndrome, which relies on toxins that act as superantigens. This causes a rapid release of huge amounts of cytokines. Of course, there is some overlap in these categories. For instance, necrotizing fasciitis is an invasive infection where bacteria are spreading along fascial planes, but there's also a part that toxin production plays in causing that tissue necrosis. Now let's move on to some streptococcal skin infections. This is also in the study guide. What skin infections can be caused by both strep pyogenes and Staph aureus? Either of these bacteria can cause cellulitis, which is a deep skin infection. Here's an image of cellulitis of the leg. So you notice the redness and the edema. This is usually warm and very tender to the touch. This is super common. Anytime you are on call in internal medicine, you will be admitting somebody with cellulitis. Now, just to throw in a clinical pearl for cellulitis, when you have a patient admitted with cellulitis, one of the first things you want to do is take a pin and just mark a line around the red area. And that way you can pretty easily determine how quickly it's progressing or improving. Patients are often a little dubious of this technology that I'm talking about right here, but I'm telling you that this ballpoint pen is probably the best tool that we have for measuring improvement in cellulitis. And now, moving on to impetigo. Impetigo is another that can easily be caused by strep or by staph species. Impetigo is a superficial skin infection that's characterized by redness and little vesicles or blisters. And these vesicles then rupture, leaking a yellowish fluid and causing honey-colored crusting of the lesions. It usually affects kids' faces, often around the nose, mouth, and cheeks. Let's finish our Group A strep discussion by talking about its immunological complications. You're going to see this information again in the course, but this is one of those topics that you may want to review a couple of times. Remember that in the immunological complications, tissue destruction is not due to the bacteria itself, but it's rather due to the body's immune response to the bacteria. So in rheumatic fever, you have group A antibodies attacking the heart, probably because there are antigens in the heart tissue that resemble those of group A strep. To diagnose rheumatic fever, we use the Jones criteria. First, you have to prove that there was a recent group A strep infection, and then you need to observe typical manifestations of rheumatic fever in that patient. They need to have 2 major criteria or 1 major and 2 minor. The major criteria can actually spell out Jones, which is very helpful. The J is for joints, which describes a migratory polyarthritis. The O is supposed to be shaped kind of like a heart. It's a little bit of a stretch, but not too much. The heart represents pancarditis. Pancarditis means you can get endocarditis, myocarditis, and pericarditis. N is for nodules. These are subcutaneous nodules, sometimes referred to as Aschoff nodules. The E is for erythema marginatum. This rash will start small and then it spreads out into a large ring. The rash can appear and disappear over the span of a few hours. And the S is for synonym chorea, and this is sometimes called St. Vitus dance. It's characterized by uncoordinated movements of the face and the limbs. Now, for the minor criteria, these are kind of nonspecific and less important for test taking. They include arthralgia, fever, elevated ESR or CRP, and a prolonged PR interval on your EKG. Like I said, I think the major criteria are more important to know than the minor criteria, so I want you to pause the video and take this opportunity to write out the Jones major criteria. Remember that these are the ones that are supposed to spell out Jones. Good. Now let's move on to strep A galactiae, more commonly referred to as group B strep. And sometimes you're going to hear it referred to as GBS. So GBS is the same as group B strep and is the same as strep A galactiae. Remember that group B strep is another beta hemolytic strep, like group A strep. What does group B strep cause? Well, it depends on who you are. It causes pneumonia, sepsis, and meningitis in babies, especially in those whose mothers were colonized with group B strep in their genitourinary tract. In pregnant women, group B strep can cause asymptomatic bacteriuria, urinary tract infection, postpartum endometritis, and bacteremia. In non-pregnant adults, we frequently see group B strep in bacteremia and in skin and soft tissue infections. Let's look at that study guide again. Why is group B strep so common in neonates? The reason why it's so common in neonates is because it's a normal vaginal flora in about 25% of women. These women are, for the most part, asymptomatic carriers. Group B strep rarely causes problems for them, but we know that infants born to women who are colonized with group B strep are more likely to develop group B strep infections than infants who are born to women who aren't colonized. The second part of this question asks what types of infections group B strep usually causes in neonates. Well, it frequently causes meningitis, pneumonia, and sepsis, which are clearly very serious complications. So what do we do about this risk? The CDC recommends that obstetricians usually do a vaginal and rectal swab to detect group B strep colonization at 35 to 37 weeks gestation. If the pregnant woman is colonized in the GI or GU tract, or if she had a positive urine culture for group B strep during her pregnancy, then we give prophylactic penicillin during labor. The sole reason for doing this is to protect the infant from infection with group B strep. And just as an FYI, there are 3 organisms that I want you to think of when you see a question about neonatal sepsis. And those are group B strep, E. coli, and Listeria monocytogenes. We'll go over those again later in the course, but repetition is a good thing. All right, moving on to the next division in the gram-positive organism algorithm, Enterococci. Enterococci are gram-positive cocci that are catalase negative, and therefore they are listed with the streptococci. These usually exhibit gamma hemolysis, which is actually the same as saying no hemolysis. Just look at the name of the organism and it can tell you itself where it lives. Entero refers to the intestinal tract, and cocci refers to its spherical shape. So when you hear the species names, it becomes even more clear. Enterococcus faecalis and Enterococcus faecium. So feces is included in both of these species names. Not an attractive name, not one that I would want, but very descriptive. You know exactly what you're dealing with by just hearing that name. Enterococci are usually normal gut flora. They're typically not very virulent, but they can definitely cause infection if they end up in a sterile place where they're not supposed to be. Enterococci are known to cause endocarditis and urinary tract infections, especially in the hospital setting. Enterococci, though not very virulent, are known for antibiotic resistance. So when they indeed end up causing a clinical infection, they can be very difficult to treat. If you hear the term VRE, it refers to vancomycin-resistant Enterococcus, which can be a bear to deal with in hospital units with many chronically ill and immunocompromised patients. One other thing that I want to mention here is the confusion that can occur with Enterococcus and Enterobacter. Enterobacter is a gram-negative rod, and Enterococcus is a gram-positive coccus. Be sure not to confuse them. They're very different. All right, moving on to Streptococcus bovis. Strep bovis is another type of group D strep. So we had group A strep, there's group B strep, and there's this category called group D strep. Enterococcus used to be called group D strep, but now it's been reclassified. However, strep bovis continues to be referred to as group D strep. Strep bovis used to be considered one species, but it's now been divided into 4 species in the Streptococcus bovis group. These 4 species are Strep Galileticus, Strep lunatiensis, Strep infantarius, and Strep pasteurianus. I don't think that you need to remember these species, but you'll need to know the significance of Strep bovis as a group. Strep bovis is found in the gut. When it accesses the bloodstream, it can cause endocarditis. There's an association that you must remember regarding Strep bovis. When Strep bovis is found in the bloodstream or as a cause of endocarditis, the patient must be evaluated for colon cancer with colonoscopy. There's a lot of debate about what part the Strep bovis plays in the development of colon cancer, but regardless of its role in causation, there's an association between Strep bovis and colon cancer. In patients with Strep bovis endocarditis or bacteremia, about 15 to 30% of them will have colon cancer. So remember that association between Strep bovis bacteremia or endocarditis and colon cancer. Now it's time for your end of session quiz, so I want you to pause your video, go through those questions now, and then restart your video so we can go through them together. All right, let's go through these answers to the quiz, and this is a short one. First question, what organisms are most commonly implicated in subacute infective endocarditis? Viridans streptococci. These are probably the most common cause of subacute infective endocarditis. The other common causes include enterococci, Streptococcus bovis, and coagulase negative Staphylococcus like Staph epidermidis. The Haysick organisms, now these are not gram-positives, but you should know them as a possible cause of subacute infective endocarditis. Haysick stands for Haemophilus species, Aggregatibacter species, which was previously called Actinobacillus, Cardiobacterium hominis, Eikenella corrodens, and Kingella kingae. And the next one, what types of disease processes are caused by strep pyogenes or group A strep? Group A strep can cause disease by multiple different mechanisms. We talked about how group A strep can cause superficial or invasive infections such as pharyngitis, impetigo, cellulitis, and bloodstream infection. We also talked about toxin-mediated effects of group A strep infections like toxic shock syndrome. And finally, we mentioned the immune-mediated processes associated with group A strep infections like post-streptococcal glomerulonephritis and rheumatic fever. All right, that's the end of your end of session quiz and the end of your video on Streptococcus. I'll see you again next time.
It's time for another 3-question warm-up. Let's get going. First question here, which embryologic structure of the heart gives rise to each of the following adult structure? So first we have the ascending aorta in the pulmonary trunk. That's going to come from the truncus arteriosus. Next we have the coronary sinus. That's going to be derived from the left horn of the sinus venosus. And then next we have the superior vena cava, and that's going to be the right common cardinal vein and the right anterior cardinal vein. Next question. What is the karyotype in Klinefelter syndrome? What is the karyotype in Turner syndrome? So remember, in Klinefelter, that's going to occur in males who are genetically 47XXY. Now, as a reminder, these patients are very tall with long extremities. They're going to have some testicular atrophy and gynecomastia. Those are going to both be common presentations in Klinefelter. Then we have Turner syndrome. That's going to occur in females who are 45XO. You might recall these patients have short stature, a neck webbing, and a shield chest. Next question. Which amino acids are found in large concentrations in collagen? So remember, in collagen, you're going to find lots of glycine, lots of proline, and then hydroxyproline. All right, that's it for the warm-up. Let's get to that lecture now.
So far we've covered staph species and strep species, and now we're going to cram all the other gram-positive bacteria into a single video, or at least the bacteria you're likely to see on step 1. And we're going to start with 2 types of gram-positive bacteria that form spores. Spores are a dormant form of bacteria that are formed when conditions get harsh or when nutrients get limited at the end of the stationary phase of the growth curve to avoid dying off completely. Spores are extremely hardy, and they tend to be resistant to lack of nutrients, desiccation, heat, cold, disinfectant chemicals, that sort of thing. So when times get tough, certain bacteria, specifically Bacillus species and Clostridium species, will form spores that can lay dormant in inhospitable conditions until more favorable environmental conditions arise, and then they can become actively replicating bacteria again. Now, USMLE occasionally asks questions about sterilizing surgical equipment, so it may be worth knowing that you can kill bacterial spores by autoclaving at 250 degrees Fahrenheit, which is 121 degrees Celsius, for about 15 minutes. Now, these are spores of Bacillus anthracis, the bacteria that causes anthrax. And here you see Clostridium tetani, which is the bacteria that causes tetanus. So the gram-positive rods are the normal bacteria, but on the ends of some of them, you can see these little spores forming, which make the bacteria look a little bit like a chicken leg. We're going to cover Clostridium and Bacillus in a moment, but I also want to briefly mention another spore-forming bacteria, which is Coxiella burnetii. Coxiella is a gram-negative rod that causes Q fever. We're going to cover it in the video on zoonotic diseases. But back in the 50s and 60s, when the U.S. government had a biological weapons program, it included stockpiles of Coxiella and Bacillus anthracis and botulinum toxin, all from these spore-forming bacteria. Let's dig into the bacteria in the genus Clostridium. Now, these are all very testable, and at least one of these is something you're probably going to see a lot of in the hospital. Clostridia are spore-forming gram-positive rods that are obligate anaerobes. There are 4 main Clostridium species that we're going to discuss. Clostridium difficile, or C. diff, is one that you'll probably get to know all too well during your clinical years. C. diff makes 2 major toxins, toxin A, also known as enterotoxin, and toxin B, or cytotoxin. So toxin A binds to the brush border of the gut and leads to intestinal fluid secretion and inflammation. And toxin B, which is even more potent, causes disruption and dysfunction of the actin cytoskeleton in the intestinal mucosal cells. Now, this results in pseudomembranous colitis, where inflammatory debris forms a film or pseudomembrane that covers the mucosal surface of the colon. C. diff colitis usually manifests as diffuse, watery diarrhea. It may lead to dilation of the colon, called toxic megacolon, and even perforation of the colon. And the primary risk factor for developing C. diff colitis is antibiotic use. So you inadvertently kill off the normal colonic flora with your antibiotics, and that allows C. diff to overgrow, and that leads to colitis. So anytime you have a patient with new diarrhea while taking antibiotics, you need to think about the possibility of C. diff. And C. diff colitis can even occur after the patient has completed their antibiotic course. So you have to ask about recent antibiotic use in any patient with diarrhea. Clindamycin is a very common culprit, but really any antibiotic can do it. So if you suspect C. diff colitis, how do you diagnose it? Well, you can check for C. diff toxin in the stool, either by PCR or by ELISA. And then how do we treat C. diff colitis? Well, first-line treatments include either metronidazole in patients with mild disease or oral vancomycin for more severe disease. Metronidazole can be given either orally or intravenously because the metronidazole is actually excreted into the bowel, and so it can treat the infection there. And we usually give vancomycin IV, but vancomycin is not excreted into the bowel, so IV vancomycin is useless for C. diff colitis. And oral vancomycin is not absorbed by the GI tract, so it's all going to stay in the gut and kill the bacteria. Another newer treatment option is a macrolide antibiotic called fidaxomicin, which is mainly used for recurrent C. diff colitis that's not responding to anything else. And then another option is the fecal transplant or fecal bacteriotherapy, which is where you take feces from a healthy donor and you infuse it into the C. diff patient's colon as an enema. So the idea is that you're transplanting all those normal, healthy bacteria into the patient who has C. diff, and it works well in about 90% of patients. And on that slightly unsavory note, let's move on to another Clostridium species, which is Clostridium tetani. Clostridium tetani is the bacteria responsible for tetanus, which, thanks to immunization, we don't really see much anymore. Clostridium tetani forms spores that can survive in the soil for long periods of time. So you step on a nail or you get some type of puncture wound, and then the spores from the soil enter the wound and transform into this gram-positive rod that can produce tetanospasmin or tetanus toxin. So we discussed that one in the video on bacterial toxins. Tetanospasmin blocks the release of inhibitory neurotransmitters like GABA and glycine, resulting in increased firing of motor neurons. And this leads to muscle spasms and trismus, or lockjaw, that tetanus is well known for. Now, as I said, we prevent this illness with tetanus immunizations. In general, people need tetanus boosters every 10 years. So if a patient seeks medical care for some wound and he hasn't had a booster in the last 5 years or more, it's recommended to go ahead and give a booster at that point. Our third species is Clostridium botulinum. So this species produces a heat labile toxin that inhibits acetylcholine at the neuromuscular junction, causing a flaccid paralysis. And remember, we don't recommend giving honey to babies because honey may contain Clostridium botulinum spores. So these spores can transform into reproducing bacteria, which can eventually populate the intestine and produce botulinum toxin that causes symmetric weakness in babies. And then Clostridium perfringens is the last one. Remember, this is one that can produce alpha toxin, a phospholipase that causes gas gangrene and myonecrosis, as well as an enterotoxin that's responsible for a large number of food poisoning cases. Now let's talk about the other spore-forming gram-positive rod, Bacillus anthracis. So this is the bacteria that causes anthrax. Bacillus anthracis produces anthrax toxin, which has 3 components: edema factor, lethal factor, and protective antigen. Now, anthrax can cause different syndromes depending on where the spores land in the body. There's alimentary tract anthrax, cutaneous anthrax, and inhalational anthrax. Cutaneous anthrax is the most common form. This occurs when spores get under the skin, usually through a small skin wound. So a small papule appears first, and then that transforms into a large, painless ulcer with central necrosis, seen as a large, depressed, black eschar. There's often a significant area of edema and erythema surrounding this ulcer due to toxin production. So this is a woman with Bacillus anthracis infection of the soft tissue around the eye, showing all that soft tissue edema that occurs with this disease. And this is an example of that large necrotic ulcer with a black eschar. And this is a lady who worked in a goat hair processing mill, which I didn't really know was a thing. But cutaneous anthrax occurs as a result of handling animals or animal products that contain the Bacillus anthracis spores. And in this case, the spores were in the goat hair. The other form of anthrax you're likely to be tested on is inhalational anthrax or pulmonary anthrax. So if anthrax spores are aerosolized and they're small enough to reach all the way down into the alveoli, they can be phagocytosed and taken to the mediastinal lymph nodes where the toxins cause trouble. So what you see on chest x-ray is mediastinal widening from that lymphadenopathy. The bacteria can then enter the circulation and cause widespread infection and sepsis and death. This form of the disease is sometimes called wool sorter's disease because the anthrax spores contained in contaminated wool would be aerosolized and inhaled by wool workers, people working with wool. Now, these days, we're a little more concerned about transmission by weaponization of anthrax spores, as a bioterrorism weapon. I mentioned that Clostridium species are obligate anaerobes. But obviously, if Bacillus anthracis can live in the lungs, it must be able to tolerate an oxygenated environment. But it's not an obligate aerobe. An obligate aerobe requires oxygen in an aerobic environment to grow and produce energy. Bacillus anthracis is a facultative anaerobe, meaning it can also grow in an anaerobic environment. Clostridium species, on the other hand, are obligate anaerobes. This means that Clostridia cannot grow or produce energy when oxygen is present. Now, other bacteria that are obligate anaerobes include Actinomyces, which we're going to talk about next because it's another gram-positive, and also the gram-negative rod Bacteroides. So those are all obligate anaerobes. And as a reminder, what antibiotics do we typically use for anaerobes? Classic antibiotics should come to mind are metronidazole and clindamycin. At the top right of the gram-positive algorithm, there's a section for branching filaments. So these are gram-positive organisms that have a filamentous growth, resembling fungal hyphae. These include Actinomyces and Nocardia. Here's a photomicrograph from a brain abscess that shows Actinomyces israelii using fluorescent antibody staining. So you can see the shape of the filamentous growth. Actinomyces are anaerobic organisms that can colonize the oropharynx and the GI tract. Now usually they don't cause any problems, but occasionally Actinomyces will cause cervicofacial infections, infections around the face and neck. Usually it's in the area of the jaw, the mandible. So this man has developed an Actinomyces infection near the TMJ, the temporomandibular joint. So usually what you see is inflammatory changes on the skin, then development of sinus tracts that drain pus and what we call sulfur granules. Now these sulfur granules don't really contain sulfur. They contain colonies of yellow pigmented bacteria surrounded by white blood cells, and they look a bit like granules of sulfur. So the mnemonic was that Israel has yellow sand, so Actinomyces israelii has yellow pigment that can be seen in these sulfur granules. Now do you remember the other bacteria known for producing a yellow pigment? Staph aureus. Remember, aureus means gold. Now let's contrast Actinomyces with Nocardia, the other filamentous bacteria. Nocardia is a gram-positive filamentous rod that is partially acid-fast, meaning that it stains with the acid-fast staining used for mycobacteria. That's usually going to be your clue on your test questions. Nocardia looks a lot like Actinomyces, but it's aerobic, whereas Actinomyces was anaerobic. Nocardia is fairly ubiquitous. It's found everywhere, in soil, dust, decaying vegetation. It's also part of the normal oral flora. It usually causes infections in immunocompromised patients, either by inhaling it or having it inoculated into the skin. This is a pretty severe case of cutaneous nocardia, but it's a good example of the skin lesions that you can see. Let's get back to some of the more common gram-positive rods, like Listeria monocytogenes. Listeria is a facultative intracellular organism, so it doesn't have to live inside your cells, but it can. Sneaky, sneaky. It enters the body through the GI tract through unpasteurized milk and cheese and also contaminated deli meats. So it enters the body through the GI tract, it penetrates the intestinal mucosa, and it's eventually taken up by the monocytes. So the name Listeria monocytogenes is a good clue to help you remember that it's an intracellular parasite that likes to live inside of monocytes. Now, if a pregnant woman is infected, the bacteria can cross the placenta, resulting in fetal loss or neonatal sepsis. So you remember the three major organisms associated with neonatal sepsis? Group B strep, E. coli, and Listeria. So this is why pregnant women are told not to eat soft cheeses or drink unpasteurized milk or even deli meat during pregnancy. Now, the main groups at risk for Listeria infection are infants, especially newborns, the elderly, immunocompromised individuals, and pregnant women. The last bacteria we're going to discuss in this video is Corynebacterium diphtheriae. the scourge of spelling bee contestants throughout the land. Again, this is a gram-positive rod, but it has these protuberances on either end of the rod, kind of like a club. That's where the name comes from. Karuna is a Greek word for club. Not that kind of club. The kind of club you would use to bash somebody's head in if you were a caveman or something. And as you might also guess from the name, this is the organism that causes diphtheria. But many of the clinical manifestations of the infection are actually due to production of exotoxin. Diphtheria toxin is an ADP ribosylator of elongation factor 2. Now, you reviewed this in the video on bacterial toxins. Do you remember another bacteria that produced a toxin that inactivates EF2? Pseudomonas aeruginosa. It produces exotoxin A, which has a very similar mechanism of action. Diphtheria toxin can damage nerve cells and also heart cells, so diphtheria can cause cardiac arrhythmias and myocarditis. But the most striking manifestation is pseudomembranous pharyngitis. You see whitish patches in the posterior oropharynx that coalesce into a grayish membrane that adheres very tightly to the surface. And if you try to scrape this off, it bleeds profusely. Now, this membrane can proliferate within the respiratory tract and can be associated with mucous membrane inflammation, which causes a so-called bull neck of diphtheria. Lots of soft tissue swelling, which is pretty bad for respiratory function. Now, making the diagnosis of diphtheria requires both a positive culture and proof of toxin production, either by PCR or a test called the ELIC test, which is where you put a special filter paper on the culture medium and then the toxin precipitates out on that paper. Now, we don't see diphtheria very often in the U.S. anymore because we immunize children against it. This is the D in the DTaP vaccine or the DPT vaccine. But diphtheria is not uncommon in other parts of the world. So, how do we treat it? Well, infected patients need antibiotics such as erythromycin or penicillin to kill the bacteria, and also antitoxin to inactivate the diphtheria toxin. You also need to vaccinate these patients after they start to get better because natural infection does not induce protective immunity. Now it's time for the end of session quiz. So pause the video and answer those questions, then we'll go over the answers together. First question, which gram-positive organism matches each of the following statements? An infant with poor muscle tone should make you think about Clostridium botulinum and botulinum toxin. Diarrhea after using antibiotics, think about Clostridium difficile or C. diff. A gray-white membrane in the posterior oropharynx of an unvaccinated child is Corynebacterium diphtheriae, causing diphtheria. Serious neonatal infection, think about group B strep or listeria. And the third one was E. coli, which is actually a gram-negative. Nodular skin disease containing gram-positive filamentous rods that are partially acid-fast is nocardia. Gram-positive rods spread in unpasteurized milk and contaminated deli meat is Listeria monocytogenes. And then respiratory distress in a postal worker is a clue for Bacillus anthracis. So back in 2001, right after the September 11th attacks, there were some bioterrorism attacks in which anthrax spores were mailed to senators and also news media. And a handful of people got sick and died. So if they give you a clue related to the Postal Service plus pulmonary disease, they might be trying to point you toward pulmonary anthrax. Next, which patients are most susceptible to Listeria monocytogenes? Remember, infants, the elderly, immunocompromised, and pregnant women are all especially susceptible. And remember, Listeria can cross the placenta and cause fetal demise. Next, which bacteria are spore formers? So the spore-forming bacteria we went over were Bacillus and Clostridium species. So that includes Bacillus cereus, Bacillus anthracis, Clostridium perfringens, Clostridium tetani, Clostridium difficile, Clostridium botulinum, and then you should also remember Coxiella burnetii. And the last question, which medications are commonly used to treat C. diff colitis? So metronidazole or oral vancomycin are first line, and then fidaxomicin is another option for recurrent C. diff colitis. We also have one rapid-fire fact. Branching filamentous gram-positive rods with so-called sulfur granules, that's Actinomyces israelii. That's it for now. I'll see you next time. Let's go over the warm-up review. First question, what is the time frame for each of the following steps of wound healing? So the first one is infiltration of macrophages and epithelial cell migration. Well, this happens in the first 1 to 3 days, with epithelialization taking place mainly in the first 48 hours. Then granulation tissue begins to develop around day 3, especially around the wound edges, and this persists for several weeks. And then infiltration of neutrophils happens in acute inflammation in the first 24 hours. Next, what are the signs and symptoms of left-sided heart failure? Well, left-sided heart failure causes pulmonary or respiratory symptoms. Remember, L for left and L for lungs. So patients with left-sided heart failure may have dyspnea on exertion, orthopnea, and paroxysmal nocturnal dyspnea. And on exam, there might be RALS or evidence of pulmonary edema. And the last question, which genetic abnormality is associated with endocardial cushion defects? It's trisomy 21 or Down syndrome. Now it's time for the lecture.
Hello everyone, I'm Dr. Shuford and welcome to our Step 1 video on gram-negative bacteria. Actually, this is the first lecture of 2 on gram-negative bacteria. There are so many little nasty gram-negatives, so many diarrhea-causing organisms that we can fill 2 whole lectures with them. So here we go, enjoy. Let's get started with our gram-negative pathogen algorithm. We have provided a PDF of the blank algorithm so you can practice filling it out. This is similar to the one that we used with the gram-positive lectures. This is really high yield again. I wish it wasn't, but it is. So we'll go through most of it together as we make our way through this session. Now the first thing you need to remember is that gram-negatives look pink on gram stain. Remember that pink equals gram-negative. Okay, now look at the algorithm and let's talk about the gram-negative cocci. So what does this include? It includes Neisseria meningitidis, Neisseria gonorrhoeae, and Moraxella catarrhalis. Now, all of these are oxidase-positive bacteria, but it may be helpful to know how to differentiate these 2 clinically significant Neisseria species. Neisseria meningitidis is a maltose fermenter, and Neisseria gonorrhoeae is a maltose non-fermenter. Next are the coccobacilli, or coccoid rods. These include Haemophilus influenza, which we'll talk about more in a few minutes, Bordetella pertussis, which causes whooping cough, Pasteurella, which is common in cat bites, and Brucella, which causes brucellosis. Next, we're going to move on to the gram-negative rods, also known as bacilli. You can differentiate these by their ability to ferment lactose. So the lactose fermenters are pink colonies on MacConkey's agar. Then these pink lactose fermenters can be further differentiated by being a fast fermenter or a slow fermenter. One way to remember the fast and the slow fermenters are by thinking of the word MacConkey's. If you change the final Y to an E on MacConkey's and capitalize the CKEES, it may help you to remember the lactose fermenters as well as the fast and slow fermenters. I think it's helpful anyway. So the C is for Citrobacter, the K is for Klebsiella, and the E is for E. coli. The second E is for Enterobacter, and the S is for Serratia. The 3 in the middle, the KEE, those are the fast fermenters. And the 2 on the ends, the C and the S for Citrobacter and Serratia, those are the slow fermenters. Now, those were our lactose fermenters. They turn pink on MacConkey's. What about the lactose non-fermenters? Well, these are going to be white or colorless on MacConkey's. They can be further differentiated into either being oxidase negative or oxidase positive. So the oxidase negatives are Shigella, Salmonella, and Proteus. The only oxidase positive non-fermenter that we're going to talk about is Pseudomonas. We have another subcategory of gram-negative bacteria that have a curved shape. The 3 bacteria in this category are Campylobacter jejuni, Helicobacter pylori, and Vibrio cholera. Campylobacter can have more of an S shape, and Vibrio is described as having a comma shape. They're oxidase positive. 3 other facts that might be useful to know: Campylobacter jejuni grows in a relatively warm environment at 42 degrees Celsius. H. pylori produces urease, and Vibrio cholerae grows in an alkaline media. So that's the gram-negative algorithm. I wish there was a really quick way to memorize it, but the truth is you're just going to have to stare at this for a little while and fill in some blank algorithms on your own till you're comfortable with it. For now, let's press on and learn a little bit more about these gram-negative organisms. But don't worry, we're not going to cover all of these in this lecture. We are going to spread the joy of gram-negative pathogens over a couple of lectures. All right, let's begin. Look at this image. It's showing you some gram-negative cocci. Actually, it might be better described as showing diplococci. When you hear diplococci, you immediately think strep pneumo, but that would be gram-positive diplococci. And while we're on gram-positives, do you remember what you're supposed to think if I say gram-positive clusters? Well, that should make you think staphylococci. But now these are gram-negative diplococci. That should make you think Neisseria species. These ferment glucose and produce an IgA protease. The two most important species for you to remember are Neisseria gonorrhoeae and Neisseria meningitidis. And though these share a genus, they have a whole lot of differences. First, we have Neisseria gonorrhoeae, or gonococcus. This is primarily a sexually transmitted infection. Once mucosal infection is established, it can travel hematogenously and cause septic arthritis. If a 21-year-old sexually active person comes to your office with septic arthritis, the first three things on your differential should be gonococcus, gonococcus, and gonococcus. Now, babies can be infected while traveling through the birth canal and can get conjunctivitis. As we mentioned before, Neisseria gonorrhoeae is a maltose non-fermenter. Also, you should be aware that it does not have a polysaccharide capsule. Now, as for treatment, we use a combination of ceftriaxone and azithromycin. This combination is intended to try to overcome resistance issues that are becoming an increasing problem with gonorrhea, as well as cover any coexisting chlamydia trachomatis infections. Now for Neisseria meningitidis, or meningococcus. Unlike Neisseria gonorrhoeae, Neisseria meningitidis is a maltose fermenter. It has a polysaccharide capsule and it can be transmitted by respiratory secretions. This is a very, very, very bad bacteria. It probably won't surprise you that Neisseria meningitidis causes a lot of meningitis, but you need to know that it can cause meningitis alone, it can cause a bloodstream infection alone, or it can cause a combination of both. It's a common cause of bacterial meningitis in children and young adults and has a mortality rate between 10 and 15%, so it's a big deal. When the infection is in the bloodstream, it can cause disseminated intravascular coagulation, purpura fulminans, and shock. Now, it's the disease that's associated with Waterhouse-Friderichsen syndrome. And what's that? Remember that that's an adrenal hemorrhage that's due to overwhelming infection with Neisseria meningitidis. Luckily, there is a vaccine for meningococcus, and recently there has been a new serogroup B meningococcus vaccine licensed for use in the United States. Rifampin, ciprofloxacin, and ceftriaxone can be used as prophylaxis in people who have close contact with infected individuals. Treatment for overt disease should be implemented immediately and empirically. You do not wait for culture results in these people. Use ceftriaxone or cefotaxime, and you should only use penicillin G if you have sensitivity data showing that treatment will work. Okay, let's talk about Haemophilus influenzae. Remember that Haemophilus influenzae, or H. flu, is a coccobacillus. Influenzae is a bit of a misnomer. This was named years ago because they thought it might be the cause of flu, but it's not. Haemophilus influenzae is a bacteria, and the influenza virus that causes influenza is obviously a virus. So what infections can Haemophilus influenzae cause? There are two really big ones to remember that have been drastically reduced by the Haemophilus influenzae type B vaccine, and those are epiglottitis and meningitis. Here's a photo of a child with epiglottitis. Now, epiglottitis occurs when the epiglottis becomes inflamed, which can then cause airway compromise. What you see is a really sick kid with difficulty breathing and swallowing. They may actually be drooling because of the difficulty swallowing and breathing, and this can make them very anxious as well. Now, there's something called the sniffing dog position. They kind of stick out their neck, trying to open their airway more so that they can breathe. On examination, you may see a very red and inflamed epiglottis. On x-ray, you may see something called the thumb sign, which is caused by the edema of the epiglottis. So one thing you need to know is what to do for a kid that you think has epiglottitis. This does show up occasionally on tests. And most of the time, the answer is going to be something like, make the kid comfortable and don't do anything. You shouldn't go poking and prodding a kid with epiglottitis until you have a plan to secure that airway, which means being able to rapidly intubate them. Worst case scenario, which is what we always have to think about, right, is that they start crying and they lose their airway and then they die. Now, meningitis is the other big one that I mentioned for H. flu. It used to cause a ton of morbidity and mortality in kids prior to that Hib vaccine, but we hardly see any H. flu meningitis in the United States now, thank goodness. Now, I keep talking about Haemophilus influenzae type B, and this refers to a specific serotype of H. flu. The 6 serotypes of H. flu all have capsules and can be differentiated. There are also a number of non-typable strains of H. flu. Now, these strains don't have capsules, but they are still major causes of disease. These strains cause a lot of sinusitis, otitis, and pneumonia. A couple more things to remember about H. flu. It produces an IgA protease, which can probably help it to cause those mucosal diseases that we see. Now, if you want to culture this, you have to culture it on chocolate agar, and it requires factors 5 and 10 for growth. One other Haemophilus species is Haemophilus ducreyi, which causes the sexually transmitted disease chancroid. What you see is one or several painful ulcers that are often associated with inflamed inguinal lymph nodes. Now, don't get chancroid confused with syphilis. Syphilis causes a painless ulcer, but the Haemophilus ducreyi ulcer is painful. Just remember that patients with Haemophilus ducreyi do cry over the pain in their chancroid ulcers. Okay, now let's move on to Legionella. Legionella is another gram-negative rod. We didn't cover this one in the algorithm because it has some unique qualities. It's most well known for causing Legionnaire's disease, which is a severe atypical pneumonia with fever. It's frequently associated with GI symptoms like diarrhea. Now, there is another clinical presentation of Legionella infection called Pontiac fever, and this is more of a mild flu-like illness that resolves without treatment. Legionella can be difficult to diagnose. It doesn't grow on routine culture media, but it grows best on buffered charcoal yeast extract agar, and it requires iron and cysteine to grow. And though it's a gram-negative rod, it gram stains poorly because of this unique lipopolysaccharide in its outer membrane. It may be visible on silver stain, but even that can be low sensitivity. Now, there's an old mnemonic that's been used for ages to help remember all of these characteristics. You can imagine a French legionnaire with a silver helmet, which should remind you of the silver stain, standing by a campfire, and that's where we get our charcoal, and with his iron dagger, he's no sissy, and sissy should remind you of cysteine. So we're getting most of the unusual aspects of Legionella here. We see the silver, charcoal, iron, and cysteine. It's a bit of a stretch, but sometimes the weirder the thing, the easier it is to remember. Because of the complexity of growing Legionella, we often try to detect the presence of Legionella antigen in the urine for a quick diagnosis. The only problem with this approach is that it detects only serotype 1 of Legionella pneumophila. Thankfully, the bulk of clinical disease is caused by this serotype. Now, for transmission, this is super important, so concentrate here. Legionella is spread through aerosols from environmental water sources. There's no person-to-person transmission. You may read a scenario on a test where several people get pneumonia and they've all been exposed to a common air conditioning system or sprinkler system or some sort of water feature. Now, the treatment is a macrolide like erythromycin or azithromycin or a fluoroquinolone. All right, next we're going to move on to Pseudomonas aeruginosa. This is yet another gram-negative rod, and this is an important one to know. There are a few hints that will be given to you in test questions and in real life to alert you to a Pseudomonas infection. Pseudomonas is a lactose non-fermenter that is oxidase positive. It produces an unusual blue-green pigment, and it has a fruity, sweet smell to it. Pseudomonas is a real problem in certain populations. It causes a lot of ventilator-associated pneumonia. It also colonizes the airways of cystic fibrosis patients. Other places that you're going to find Pseudomonas is in wounds of burn victims and in hot tubs as the cause of hot tub folliculitis. It might help you to think about Pseudomonas loving the water and loving the air. Air because it's oxidase positive and it causes a lot of lung problems, such as ventilator-associated pneumonia and colonizing the abnormal airways of CF patients. And water because Pseudomonas loves moist environments like burns and hot tubs. It produces a blue-green pigment that looks like water, so when you think of Pseudomonas, think of air and water. This bacteria has many virulence factors, including exotoxin A, which inactivates the elongation factor 2, and this results in a lot of cell necrosis. So how do we treat it? Treating Pseudomonas is a tricky business. Pseudomonas has the potential of being multi-drug resistant. So if a person looks really sick or you suspect a drug-resistant Pseudomonas, then you can start 2 anti-Pseudomonal drugs with the hope that at least one of those will be active against the Pseudomonas. The only class of oral medication with anti-Pseudomonal activity is the fluoroquinolone class, meaning something like ciprofloxacin or levofloxacin. Ticarcillin and piperacillin are anti-Pseudomonal, as are cefepime and ceftazidime. The carbapenems, imipenem, and meropenem are also active against Pseudomonas. Now let's move along to the next important gram-negative rod, Helicobacter pylori. Now this is an important one for you to remember as well. It's a spiral-shaped rod that is urease positive. Remember that part about urease. We use that characteristic to test for the presence of this bacteria. You can use a urease breath test or a urea breath test or a urease test on biopsy specimen. Other diagnostic tests include serology, and that's just looking for the antibody, or the stool antigen test. You can also look at tissue to just try to see the organism under the microscope or even try to grow it on culture from a biopsy specimen. Now this bacteria causes a lot of problems, including gastritis, and is associated with duodenal ulcers, gastric adenocarcinoma, and gastric mucosa-associated lymphomas. So this is one of those few instances where we have seen bacteria increasing the risk for cancer. So how do we treat this? H. pylori is another tough little guy, so we have to use several drugs to get the job done. There are several different versions of the triple and quadruple therapies for H. pylori. The standard triple drug regimen for H. pylori includes proton pump inhibitor like omeprazole, clarithromycin, and amoxicillin. If the patient is penicillin allergic, and then you can substitute metronidazole. Quadruple therapy usually combines 2 antibiotics, metronidazole and tetracycline, with a proton pump inhibitor and bismuth. Okay, that is it for our first session on gram-negatives. Now it's time for the end of session quiz. So go ahead and turn off that video, answer the questions, and then restart the video so that we can go through those answers together. All right, let's go through those answers to the end of session quiz in your study guide together. The first question, a gram stain reveals gram-negative oxidase-positive diplococci. What's the likely organism? So this is going to be one of those 3 things, and if they give you any clinical information with the question, it will help narrow it down to 1. If the stain is on a sputum from a COPD patient, then you should be thinking Moraxella catarrhalis. If the stain is of urethral discharge in a sexually active college student, then it's going to be Neisseria gonorrhoeae. If it's a stain on CSF culture from a patient with rapidly progressive meningitis, then you need to be thinking Neisseria meningitidis. A 22-year-old medical student has a burning feeling in his abdomen after meals. An EGD is performed and biopsy of the gastric mucosa shows spiral-shaped gram-negative bacteria. So what's the organism? Of course, this is going to be H. pylori. A 50-year-old male smoker presents with new cough and flu-like symptoms. Gram stain of the sputum shows no organisms, but silver stain shows bacilli. What's the diagnosis? Now this is going to be Legionella pneumophila. Legionella does not gram stain well, but you may be able to see it using silver stain. How do we normally identify this? The patient comes in with pneumonia and you can check a urinary antigen test for Legionella. What gram-negative organism matches these following descriptions? Sepsis, DIC, and adrenal hemorrhage. This is Waterhouse-Friderichsen syndrome of Neisseria meningitidis sepsis. 5-year-old with pharyngitis, drooling, and x-ray revealing a thumb sign. This is classic epiglottitis of Haemophilus influenza type B, which again we don't see much of anymore thanks to the Haemophilus influenza type B vaccine. Burn wound infection, this is classically Pseudomonas. Life-threatening meningitis plus purpura, again you need to think Neisseria meningitidis. Septic arthritis in young sexually active patients, remember Neisseria gonorrhoeae. And that is it for our end of session quiz, and that's it for our first session on gram-negative bacteria. I'll see you next time.
Welcome back to DIT TV. We've got more rad music coming up in just a minute. But don't forget that this Friday night, our guest VJ will be none other
than Dr. Chris Lewis, who's going to be playing some of his favorite videos. And we're going to have the world premiere of the new single, Don't Pick My Ass Car,
from Anthrax. So be sure to catch Dr. Lewis this Friday at 10 p.m. Eastern, only on DIT TV. Sponsored in part by New Coke.
Love me some New Coke. It's going places, I think. But right now, here's the title track from Billy Spinal's new album on Gram-Negative Records. It's called Pseudomonas. And hey, it's in stereo. Only on DIT TV.
Saw a patient today with Pseudomonas. He's got cystic fibrosis and bad pneumonia. Got a girl with hot tub folliculitis. diabetic with osteomyelitis, don't feel alright. I said, yeah,
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 Yeah.
yeah,
Yeah.
yeah. You make me feel
Pseudomonas,
so bad,
Pseudomonas,
so bad.
Pseudomonas,
I don't feel alright tonight,
Pseudomonas,
tonight.
Pseudomonas,
Gonna die,
Pseudomonas,
gotta say bye-bye. I said, yeah,
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 Yeah.
yeah,
Yeah.
yeah, yeah. It's oxidase positive but won't ferment lactose, and makes greenish pus wherever it grows. It makes exotoxin A blocking EF2. What can I do? I said, yeah,
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 Yeah.
yeah,
Yeah.
yeah. Need some piperacillin with
Pseudomonas,
tazobactam,
Pseudomonas,
cefepime,
Pseudomonas,
meropenem,
Pseudomonas,
aztreonam,
Pseudomonas,
ciprofloxacin.
Micro 7, 3-question warm-up. Let's do this. First question, what substances do cytotoxic T cells and NK cells use to induce apoptosis in the cells infected with virus? So they use perforin and granzymes. Next, what highly damaging events can cause irreversible cell injury? Think about calcium influx, damage to the plasma membrane, rupture of the lysosome, mitochondrial permeability, and damage to the nucleus. And the last one, what ovarian tumor matches each of the following statements? Lined with fallopian tube-like epithelium is serous cystadenoma. Ovarian tumor with ascites and hydrothorax, which we said was a pleural effusion, is Meigs syndrome of ovarian fibroma. Call-Exner bodies are seen in granulosa cell tumors. A tumor with multiple different tissue types would be a teratoma. Elevated beta-HCG is either a choriocarcinoma or a dysgerminoma, but primarily think about choriocarcinoma with that one. And then resembles bladder epithelium is a Brenner tumor. All right, let's move on to the lecture.
Hi, and welcome to our second lecture on gram-negative bacteria. There is just too much gram-negative fun to fit it all into one lecture, so here we go with part 2. First, let's talk about E. coli. There are multiple different types of E. coli. The two that are most commonly seen on tests, enterotoxigenic E. coli and enterohemorrhagic E. coli. But there are a couple more that we need to talk about, so turn to your study guide and we'll go over them. Let's start with enterotoxigenic E. coli, or ETEC. This type causes watery diarrhea by making enterotoxins. It produces a heat labile enterotoxin and a heat stable enterotoxin. This heat labile toxin is similar to that seen with Vibrio cholerae, which we know results in that rice water diarrhea that cholera is known for. The heat labile enterotoxin does this by increasing the level of cyclic AMP in intestinal cells. This causes an increase in electrolyte secretion and decrease in electrolyte absorption. And this leads to a large amount of water secreted into the lumen of the intestine, and voila, watery diarrhea. The heat stable toxin doesn't help matters at all. It stimulates that production of cyclic GMP in intestinal cells, which leads to that same result: increased chloride secretion, decreased sodium chloride absorption, followed by a lot of water loss into the lumen of the intestine. And how does that end? Watery diarrhea. These toxins cause no fever and no bloody diarrhea because nothing is invading or destroying the intestinal wall. Now, we will talk about enteroinvasive E. coli in a few minutes, and you can imagine that the story is a bit different with that one. But not this one. This one, enterotoxigenic E. coli, is a very common cause of traveler's diarrhea. And this is why you have to be careful when you're eating and drinking, traveling in resource-poor regions. Episodes are often mild and self-limited, but in more severe episodes, we can use fluoroquinolones like ciprofloxacin or levofloxacin in adults and azithromycin in kids. Now, let's move on to a different type of E. coli, intrahemorrhagic E. coli, or EHEC. One of the most common types in the U.S. is O157H7. The infective dose for enterotoxigenic E. coli is like 10 to the 8th or 10 to the 10th organisms. But for enterohemorrhagic E. coli, the infective dose is only 10 to 100 organisms. And that's it, 10 bacteria. So you can see how easily this could be spread. This type of E. coli is very serious and potentially deadly. What you need to remember about enterohemorrhagic E. coli is that it can produce Shiga toxin. It's this Shiga toxin that causes vascular damage and results in bloody diarrhea and in hemolytic uremic syndrome, or HUS. HUS is a triad of symptoms: microangiopathic hemolytic anemia, thrombocytopenia, and acute renal failure. This is very, very, very bad and can lead to death. The major reservoir for this in the United States appears to be cattle. Even healthy cattle can carry this in their gut. And a little fecal contamination in one batch of ground beef can go a long way, especially when you only need 10 organisms to cause disease. And that's why it's very important to cook ground beef sufficiently. You can go from eating a hamburger to getting really ill in a very short period of time. Treatment is usually only supportive. Antibiotics haven't proven beneficial to clinical outcome in this situation. Okay, let's move on to enteropathogenic E. coli. Now, this type attaches to the intestinal cell or the enterocyte, and by doing this, it causes effacement. This attachment and effacement results in abnormal electrolyte and water secretion, leading to diarrhea. There's no toxin production here to blame the diarrhea on. So what's interesting is that this type of E. coli is a huge problem for kids, but rarely for adults. It can cause a good bit of dehydration in kids and malnutrition in developing countries. Now, let's talk about the last type of E. coli that we'll be covering, and this one is enteroinvasive E. coli. This one is closely related to Shigella in that it invades the intestinal mucosa and can cause bloody diarrhea. Now, you might be thinking, wait, we just talked about a different E. coli that was similar to Shigella and causes bloody diarrhea. Is Dr. Schufer just perseverating on this bloody diarrhea thing and repeating the same thing over and over? Oh no, I'm not crazy. I am fascinated by fecal microbiology, which you might think is crazy. But let me tell you the difference between these two Shigella-like E. coli types. The enterohemorrhagic E. coli I just talked about a few minutes ago does not invade the cell. It only attaches to the cell and then produces Shiga toxin. That Shiga toxin causes vascular damage and thus bloody diarrhea. In the case of enteroinvasive E. coli, these bugs actually do invade the enterocyte like Shigella does, and it causes bloody diarrhea by destroying the colonic epithelium, and that invasion of the wall also causes fever. Antibiotic therapy can help limit the duration of fever and diarrhea, though not usually by very much. When we treat, we will use things like fluoroquinolones, like ciprofloxacin, trimethoprim sulfamethoxazole, or azithromycin. Those can also be effective. All of these choices depend on local resistance patterns, which are showing kind of frightening trends in most places. Okay, now let's talk about Shigella. I think we've already said enough about Shigella to give you an appropriate fear of this organism. So we've already mentioned that Shigella causes bloody diarrhea by two mechanisms. So do you remember those two mechanisms? One mechanism is actually by invading the colonic mucosa, causing inflammation and necrosis. And once it's invaded, it can travel from cell to adjacent cell, causing more inflammation and more necrosis. The second mechanism is by that Shiga toxin that Shigella dysenteriae produces. Remember, this toxin causes vascular inflammation of the colon as well as other sites in the body. It's a non-motile, non-lactose fermenting gram-negative rod that can be grown from stool culture. Shigella can be transmitted through direct person-to-person spread or from contaminated food and water. It's very infectious. You only need 10 Shigella organisms to cause dysentery. In medical school, I heard about this delivery truck driver who inadvertently spread it to a whole bunch of people who used his pen to sign for their packages. That's scary. It usually causes a small amount of bloody mucoid diarrhea along with fever, abdominal cramping, and tenesmus. In healthy people, symptoms don't usually last for more than about 7 days. Treatment is often just supportive since the disease is usually self-limited in immunocompetent people, but antibiotics can decrease the duration of clinical illness and decrease the length of time that bacteria is shed in the feces. So in elderly patients, severely ill patients, or those with immune compromise, we usually use fluoroquinolones in adults. Trimethoprim sulfamethoxazole or azithromycin are other possible treatments. Is this beginning to sound familiar? You should understand that these same treatments happen for a lot of these gram-negative diarrhea causing bugs. In these patients, you should avoid using antimotility agents, and you need to tell food handlers, people that work at restaurants and such, not to work while their stool is culture positive. Shigella is just one more really good reason to wash your hands a lot. One other fact about Shigella that's going to come up in your training is that Shigella flexneri is associated with reactive arthritis. Okay, moving on to Salmonella. Now, this is another gram-negative rod, another lactose non-fermenter, and another diarrhea causer, even bloody diarrhea. But unlike Shigella, Salmonella is motile. It has flagella. Salmonella infection can cause two different syndromes. The first is a typhoidal syndrome characterized by a systemic illness with very little diarrhea. This would be the category that typhoid fever falls into. Typhoid fever is caused by Salmonella typhi. We usually see this in developing countries where it's spread by fecal contamination in food or water, and this disease causes fever that can lead to sepsis. The clinical feature that they might mention in a test question is salmon-colored spots on the abdomen and trunk. So remember, salmon-colored spots equals Salmonella. The other clinical syndrome from Salmonella infection is gastroenteritis, which is where that whole diarrhea angle comes in. In the United States, Salmonella infection is often from exposure to chicken or eggs. Salmonella can actually enter the egg during development and survive within the egg, making any raw egg a potential exposure. The egg shells can also be contaminated with Salmonella. So remember, raw chicken and raw eggs for Salmonella. The other exposure risk that might come up on a test is handling reptiles. For example, a question might mention that a small diarrhea outbreak occurred at a daycare center where they were all playing with turtles. If there are reptiles being handled before a case of diarrhea, think Salmonella. There's usually a 1 to 3 day incubation period for Salmonella, so this is not something that will cause symptoms within a few hours. Staph aureus, which is not a gram-negative rod, can cause abdominal pain and vomiting within a few hours of ingestion because its mechanism of action is a preformed toxin. But Salmonella needs a little more time. So how do we diagnose Salmonella gastroenteritis? Once again, it would be a stool culture. Treatment of Salmonella is similar to what we've already seen with other bacterial diarrheal illnesses. Salmonella gastroenteritis is self-limited, and in otherwise healthy adults, they don't need treatment, and antibiotic therapy has not been found to improve outcomes. So supportive care is what's really necessary there. However, in severely ill patients or those with a really high fever, antibiotics may be useful. Again, fluoroquinolones are first-line agents. Now, sometimes Salmonella gastroenteritis can get complicated. For example, sometimes Salmonella can spread hematogenously and cause endocarditis and mycotic aneurysms. It can also cause osteomyelitis in sickle cell patients. So if you get a question about osteomyelitis in a sickle cell patient, Salmonella needs to pop into your brain. The other association you might want to remember is reactive arthritis. Okay, on to Campylobacter. Campylobacter is a gram-negative rod that is S-shaped and is oxidase positive. Campylobacter jejuni grows at 42 degrees Celsius, so that's a little bit higher than average, so remember that about Campylobacter. Remember that it likes that hot campfire. This is another cause of inflammatory diarrhea, like Shigella and Salmonella, and like those other diarrheal illnesses, Campylobacter gastroenteritis can also be associated with bloody diarrhea. Like Salmonella, Campylobacter is associated with poultry. There is a huge problem with Campylobacter contamination of retail poultry in the United States, making it a major cause of foodborne illness here. It has about a 2 to 5 day incubation. For treatment, like others that we've talked about, Campylobacter gastroenteritis is self-limited. So treatment is usually just limited to very severe illness or high-risk patients, like immunocompromised patients or elderly patients. If you do treat, fluoroquinolones or azithromycin are recommended. Campylobacter has also been associated with reactive arthritis. And which other bacteria did we just mention that were associated with reactive arthritis? We mentioned both Shigella and Salmonella. The other association that you'll want to remember for Campylobacter is Guillain-Barré syndrome. Okay, let's talk about yet another cause of bloody diarrhea, Yersinia enterocolitica. This is a gram-negative bacillus. This is usually transmitted from contaminated food like undercooked pork, but there has been some transmission from exposure to household pets as well. Incubation is 4 to 6 days and usually causes diarrhea that's indistinguishable from other diarrheal illnesses. One important syndrome to remember with Yersinia is pseudoappendicitis. Yersinia infection can cause mesenteric adenitis and a lot of right lower quadrant pain, which leads to the misdiagnosis of appendicitis and not infrequently to appendectomy. Treatment is supportive for mild cases. Fluoroquinolones or trimethoprim sulfamethoxazole is recommended when treatment is required. Now let's talk about Vibrio cholerae. As you can see on your gram-negative algorithm, this is a gram-negative rod that's shaped like a comma, is oxidase positive, and grows in an alkaline media. What the algorithm doesn't tell you is that it's motile. It has flagellum. And now this gram-negative rod is important because it's the one that causes cholera, which kills about 100,000 people every year. Cholera is characterized by profuse secretory diarrhea. People can actually go into hypovolemic shock in 24 hours because of the massive fluid loss that occurs. The diarrhea is referred to as rice water diarrhea because it basically looks like that water that after you've washed rice in it. Now, we mentioned this earlier when we were discussing enterotoxigenic E. coli, but let's review it again here. Vibrio cholerae produces a heat labile toxin which activates cyclic AMP. This leads to chloride secretion and eventual loss of large amounts of electrolytes in water. Mortality is high with this illness because of that severe dehydration that occurs. So treatment is aggressive oral rehydration. The spread is through contaminated food and water. The good news is that it takes quite a high inoculum to infect a person, like 10 to the 8th organisms. The bad news is that someone with severe infection puts out this many bacteria in every milliliter of stool. Okay, now we're moving on to something a little bit different. Let's talk about Klebsiella pneumoniae. Klebsiella pneumoniae is a gram-negative lactose-fermenting bacteria that's normal gut flora. It causes a lot of nosocomial infections, though. It also causes infections in diabetic patients and in those with immune problems. We especially see Klebsiella pneumoniae causing hospital-acquired pneumonia and urinary tract infections. The other clinical syndrome I want you to remember for Klebsiella pneumoniae is pneumonia in alcoholics and COPD patients. The clue that you should look for in a test question is currant jelly sputum, which is thick red sputum indicative of that inflammation and necrosis that Klebsiella can cause in infected lung tissue. Now for the last gram-negative organisms that we'll be discussing in this session, Proteus mirabilis and Proteus vulgaris. Proteus does not ferment lactose. One microbiological clue to further identify this lactose-negative, gram-negative rod is its motility. Proteus colonies can swarm an agar plate and obscure other bacteria that are trying to grow there. Another microbiological clue that's important to remember for Proteus is its secretion of urease. Urease can hydrolyze urea into ammonia. So protease in the urinary tract can make the urine alkaline. This alkaline environment promotes formation of struvite stones, which can coalesce to form large staghorn calculi in the renal pelvis, as seen in this image. These staghorn calculi can cause obstruction of urine, which further promotes Proteus growth, which increases the secretion of urease, which increases the alkalinity and further enhances stone formation. So you can see how this just turns into a vicious cycle that can actually destroy a kidney. So remember, Proteus, urease, and struvite stones. All right, we've reached the end of the second gram-negative lecture. Now it's time for the end of session quiz. So go ahead and turn off your video, answer the end of session quiz questions, and then turn back on the video so that we can go through the answers together. All right, which form of E. coli causes hemolytic uremic syndrome? Remember, enterohemorrhagic E. coli, especially E. coli 0157H7. What infectious agent most likely corresponds to the following statement? Diarrhea caused by gram-negative non-motile organism that does not ferment lactose. This is Shigella. Rice water stools. This is classic for Vibrio cholerae, but remember that enterotoxigenic E. coli has a similar heat labile toxin mediating its diarrhea, so it would probably look very much the same. Diarrhea caused by an S-shaped organism. That's Campylobacter. Diarrhea transmitted from a household pet. 2 gram-negative rods from our discussion will fit here. It could be either Yersinia enterocolitica or Salmonella. Remember Salmonella from reptiles. Diarrhea caused by gram-negative motile organism that does not ferment lactose. Now this one is Salmonella. The most common cause of traveler's diarrhea, enterotoxigenic E. coli. Bloody diarrhea from eating undercooked hamburger meat. This is E. coli 0157H7. Diarrhea and right lower quadrant pain mimicking appendicitis is Yersinia. Diarrhea from consuming eggs or handling raw chicken. Now there are 2 organisms that fit this description. It could be Salmonella or Campylobacter. Please don't forget either one of these. They're both really important. Osteomyelitis in a sickle cell patient, you have to think of Salmonella here. All right, that is the end of our end of session quiz. I'll see you next time.
Let's paint some pathogens today. I love all of God's creatures, not just the cute cuddly ones either. Who's to say that bacteria aren't cute? I'll bet their moms think they're cute. So let's start with Vibrio and Campylobacter. It's easy to get these mixed up because they're both curvy bacilli. People want to sometimes describe them as C-shaped or S-shaped or sometimes comma-shaped, but that's not quite right. Let's start with Vibrio. It's a gram-negative, so let's take our fan brush and we'll start with some alizarin crimson and we'll mix in a little bit of liquid white, give it a nice warm pinkish color. There we are. Now Vibrio species are slightly curved rods, not really C-shaped, just slightly curved, just a little bit bendy. Some of them might be bent more than others, but you get the idea. Just a gentle bend. And then Vibrio have this nice long flagellum at one end. He uses that to get around in the petri dish or in your colon, wherever he happens to be. So maybe in our world, there's a happy little flagellum that lives right there. What do you say? You get to put him wherever you want. It's your painting. So that's our little friend Vibrio. Just a slightly curved bacillus with a nice long flagellum. So pretty. Not so pretty if you happen to be dying of cholera, but pretty enough to look at. Maybe next time we'll paint some rice water stools, but not today. I'll have to order some more Van Dyke Brown first. Now let's compare Vibrio to Campylobacter. Remember, some people will try to call this one comma-shaped too, or maybe S-shaped, but don't be fooled. Campylo means twisted, or bent, or crooked. So Campylobacter is a twisted bacteria, like a spiral or a corkscrew. Now, that means when you look at him two-dimensionally, he might look like a C, or maybe like an S or a Z. But remember, he's like a little spiral. And then he's got a little flagellum too, just like our Vibrio. There. He's a friendly little bugger, that Campylobacter. There's nothing wrong with having bacteria for friends.
It's time for another warm-up. Let's get going. Activation of fibroblast growth factor receptor 3 is associated with what disorder? So FGF receptor 3 is going to be achondroplasia. Next, a football player who was kicked in the leg suffers from a damaged lateral meniscus. Well, what else is likely to have been damaged? So this could be the unhappy triad. So that could be the ACL, the MCL. Those two can be injured there. Next, what is the basic equation for cardiac output? What is the Fick principle? So cardiac output equals heart rate times stroke volume. And then what is that Fick principle? So the Fick principle says that your cardiac output is equal to the rate of oxygen consumption divided by the difference between your arterial and venous O2 content. All right, that's it for the warm-up. Let's get to that lecture now.
Hello everyone and welcome to our Step 1 lecture on spirochetes and zoonotics. Now there is some good stuff in this lecture, so let's just get going. Spirochetes are spiral-shaped bacteria, and they achieve this spiral shape by having axial filaments, which are like flagella but oriented differently. These axial filaments run the length of the bacterium and allow for a rotating motion. We're going to talk about a few spirochetes today that are pathogenic to humans and important for your test, including Leptospira, Borrelia burgdorferi, and Treponema pallidum. So let's start with Leptospira interrogans. Leptospira is a spiral-shaped bacteria like other spirochetes, but it has a question mark shape at the end of its tail, like you see at the top of this image. One way to remember that this is interrogan sounds like interrogation, and thus that little question mark shape. Leptospira is found in water contaminated with animal urine. Okay, now if you see an infection associated with animal urine on your test, I want you to think of two types of infections. The first one is Leptospira, and the second one, which is associated with rodent urine, is hantavirus. So remember those two. Leptospirosis and hantavirus infection are both associated with urine. Now back to Leptospira. So how does the Leptospira infect a person? Well, when contaminated water comes into contact with mucous membranes, conjunctivae, or breaks in the skin, that's when the Leptospira can enter. The onset of illness is usually abrupt, and it starts with fever, body aches, chills, and headache. Leptospirosis is described as having 2 phases, though they often overlap in reality. The second phase is the one characterized by hyponatremia, renal failure, and liver damage with jaundice. You can also have aseptic meningitis and pulmonary hemorrhage. Leptospirosis can range from a subclinical disease to a very severe illness resulting in death. This very severe form is sometimes called Weil's disease. We see more of this in developing countries where human exposure to contaminated water sources is more prevalent, but there are definitely cases diagnosed here in the U.S. So how do we diagnose this? We use serology, that is, we look for antibodies to the Leptospira. And we treat this with penicillin, ceftriaxone, or doxycycline. All right, moving on to our next spirochete, Borrelia burgdorferi. Now you can see its spiral shape in this image. Do you know what disease this causes? I suspect that most of you do. This is the spirochete that causes Lyme disease. Now Lyme disease is very high yield for your test, so pay attention in this section. Lyme disease is a very real problem in the U.S., especially up in the Northeast. It's transmitted by the Ixodes tick. It's the most common tick-borne illness in the United States. There are several stages to Lyme disease. Stage 1 is early localized disease. The most characteristic finding at this stage is the skin lesion that's referred to as erythema migrans. Now, this is not the redness that happens as an immediate reaction to the tick saliva. When you can see that same day that you find a tick, you see a little red mark. That's not it. Erythema migrans is a red area that develops at the site of the tick bite after several days and up to 2 weeks after that bite occurred. The redness expands outwards and often has a central clearing in the middle that can be described as a target or a bullseye. The infected person may have other symptoms of a viral illness like fever or headache, body aches, and fatigue. Now, stage 2 is referred to as early disseminated disease, and this occurs weeks to months after that tick bite. This phase results from the blood-borne spread of the spirochete. The first thing that infected people may notice in this phase is the presence of multiple erythema migrans lesions. Cardiac and neurological symptoms can also become apparent in this stage. The cardiac findings include AV nodal block. Lyme carditis is unusual in that the AV block can fluctuate in severity within the same person, going from first degree to second degree to complete heart block, sometimes rapidly, and then regressing back to second or first degree heart block. Other cardiac findings can include myopericarditis. There are also several possible neurological abnormalities in the early disseminated phase of Lyme disease. You can get cranial nerve palsies, especially involving the facial nerve. One finding that's a huge clue to the diagnosis of Lyme is bilateral facial nerve palsy. This doesn't happen in many other disease states. Lyme can also cause peripheral neuropathy or lymphocytic meningitis, among other neurological problems. The third stage of Lyme disease, the late phase, occurs months to years after the tick bite. One manifestation of the disease in this phase is arthritis. The arthritis is typically an intermittent or a chronic arthritis of large joints, especially the knees. The late phase can also have neurological findings. So, how do we treat Lyme disease? Doxycycline, amoxicillin, and ceftriaxone are all used in various stages of that disease. Doxycycline is the drug of choice for early Lyme disease, stage 1, and stage 2 Lyme disease. For children under the age of 8, we use amoxicillin. For early disease, we treat for 10 to 21 days, and for late Lyme disease, you can use doxycycline or ceftriaxone, and it's given for 28 days. Okay, let's move on to the next beautiful but so unpleasant spirochete that we'll be covering today. And this one is Treponema pallidum, the causative organism for syphilis. Syphilis is usually a sexually transmitted disease, but it can also be transmitted from mother to baby during pregnancy. Now, syphilis can get confusing with its multiple stages, just like we just saw with Lyme, but it's also important to know for your test. So let's go through this together. The first phase is called primary syphilis. This phase refers to the local infection that occurs at the site of inoculation. That is where that treponema pallidum entered the subcutaneous tissues. And this usually happens through small abrasions that occur during sexual activity. And the evidence of that initial infection is an ulcer that's usually solitary and it's painless. This is a huge, huge clue in any question that you see. If they mention a painless ulcer, they are trying to tell you that this is syphilis. Because this ulcer is painless, a lot of people don't ever seek medical attention, and then it just goes away on its own. So people don't ever even think of reporting it to their physician. But the infection doesn't go away when that ulcer disappears. It just moves on to the second phase of the disease, called secondary syphilis. In secondary syphilis, we see the results of the dissemination of that infection. Infected individuals will have nonspecific symptoms like fever and malaise. A slightly more specific sign of secondary syphilis, and definitely the one that you need to remember, is a maculopapular rash involving the palms and the soles. There are a couple of other things that cause rash on the palms and on the soles. First, secondary syphilis can do it, but Rocky Mountain spotted fever can, Coxsackie A virus, and Kawasaki disease. Mnemonic for maculopapular rashes that can affect the hands and feet. You drive Kawasaki cars with your hands and your feet. Yes, I do know that Kawasaki makes motorcycles and ATVs, but it still works here. So Kawasaki disease, the CA in cars is Coxsackie A, the R in cars is Rocky Mountain spotted fever, and the S is secondary syphilis. Okay, back to secondary syphilis. The other common physical finding is large whitish raised areas and moist areas of the body and on mucous membranes, and this is called condyloma lata. Now, if a person still doesn't seek treatment at this point, the infection becomes latent. Early latent syphilis refers to an asymptomatic syphilis infection that was acquired in the last 12 months but hasn't yet been treated. Late latent syphilis means that the patient has had an asymptomatic syphilis infection that was acquired more than 12 months earlier. And lastly, there's tertiary syphilis. This refers to the late complications of syphilis infection. So what specific complications should you know about with tertiary syphilis? Well, you definitely need to know about gummas, as well as the cardiac complications. Okay, so gummas. What the heck are gummas? These are granulomatous lesions that can be found in the skin, in bones, or even in internal organs. What about cardiac complications? What do we see? Well, these often involve the ascending thoracic aorta. Syphilis causes inflammation of the intima, leading to dilation of the aorta and to aortic insufficiency. Now, the neurological complications of syphilis infection are referred to as neurosyphilis. And one important neurological complication to remember is chronic meningitis. Other important complications to remember include general paresis, tabes dorsalis, and Argyll-Robertson pupil. General paresis is a dementing illness that's associated with late syphilis. Tabes dorsalis is a disease of the posterior dorsal columns of the spinal cord and of the dorsal roots. And this leads to sensory ataxia and sudden severe stabs of pain in the body. And this type of pain is described as lancinating pain. Now, tabes dorsalis can also lead to loss of proprioception and vibratory sense in the legs, which leads to repetitive trauma to the joints of the hips and the legs. This repeated trauma can lead to Charcot joint, which is the destruction of that joint over time. We usually only see Charcot joint in diabetic patients at this point in the United States, but it was previously described in syphilis. Now, what about Argyll-Robertson pupil? Well, this is a pupillary abnormality that can be seen with either general paresis or with tabes dorsalis. And what you see on exam is a pupil that constricts with accommodation, but it doesn't react to direct light. Okay, now on to congenital syphilis. This is a super sad situation. Congenital syphilis occurs when a mother has untreated syphilis during pregnancy and the infection is transmitted across the placenta to the baby. This is most often a complication of primary or secondary syphilis in the mother during the time of gestation. So what are the signs that an infant has congenital syphilis? Well, one of the first signs is the snuffles. A blood-tinged nasal discharge that occurs in the first few weeks of life and is more persistent than a cold would be. Congenital syphilis can also result in bossing of the forehead. Bossing just means bulging. You may also see a saddle nose deformity, which is a depression of the bridge of the nose, like what's shown in this image. This image shows another result of congenital syphilis, which is Hutchinson teeth. These are notched, widely spaced teeth like you see here. Another late sign is saber shins. This is where you have an anterior bowing of the tibia. Some of these complications can be averted with early treatment, while others can't be. Now let's talk about diagnosis. To screen for syphilis, we usually start with what's called a non-treponemal test. This would be a VDRL or an RPR. These tests are checking for serum reactivity against a cardiolipin cholesterol lecithin antigen. So this is not specific for syphilis, but usually is present in people with syphilis. These non-treponemal tests are known to have false positives in a variety of other conditions as well. And there's a mnemonic to help remember some of the causes of false positive VRDL or RPR. And the mnemonic is VDRL, which is very convenient. The V stands for viruses like Epstein-Barr virus. The D stands for drugs, since IV drug users can have a false positive. The R stands for rheumatic fever, and the L stands for lupus or leprosy. And just so you know, all autoimmune diseases can cause false positives, not just lupus. And the other thing that isn't included in this very convenient mnemonic, but still important to know, is that pregnancy alone can be associated with a false positive. So if one of these non-treponemal tests is positive, then the serum is tested using a treponemal test. These tests look for antibodies against specific treponemal antigens. These tests are usually more expensive and therefore only used as confirmatory tests. One reason these serological tests are routinely performed for screening is because of the difficulty of finding organisms on stain. However, if your patient does have an active chancre, that initial ulcer, is probably teeming with these treponemes. And in that case, you can immediately get a sample and use dark field microscopy to get a quick diagnosis. So how do we treat syphilis? Penicillin G, which is the IV form of penicillin. The amount of penicillin and the route of administration depend on the stage of syphilis, but ideally you would always use penicillin. So what do you use if there is a real penicillin allergy? You use that same drug that we use for Lyme disease, doxycycline. Okay, let's go through the stages of both Lyme disease and syphilis. And now these are both important for your test. So for Lyme, stage 1 is early localized, and you see that erythema migrans, flu-like symptoms. In stage 2, the early disseminated phase, you see bilateral Bell's palsy, or that bilateral facial nerve palsy, as well as AV nodal block. And then stage 3, which is the late phase, monoarthritis of the knee or polyarthritis, and encephalopathy. Okay, now for syphilis. For primary syphilis, what do you see? You see that single painless chancre. For secondary syphilis, you get flu-like symptoms. You get a rash that can involve the palms and the soles and condyloma lata. And tertiary, you see gummus and you see aortitis. And other categories of syphilis include congenital syphilis and neurosyphilis. And neurosyphilis includes that tabes dorsalis and Argyll-Robertson pupil. Okay, so let's get away from those spirochetes and let's start talking about some zoonoses for a few minutes. Now, zoonoses keep my life interesting. Listen, I know that it's challenging enough to learn bacteria that typically inhabit human bodies without the added stress of having to learn the bacterial ecology of every kind of pet, farm animal, rodent, etc. that might be living around you or in your attic. But it does give you the opportunity to awe and amaze your family and friends by telling them the risks of every animal contact that they could possibly have that's casually mentioned in conversation. So here we go with your zoonotic education in alphabetical order. The first one, Bartonella henselae. This is the etiologic agent of cat scratch fever, and as you might suspect, this one comes from the scratch of a cat. It can also be through a bite, and the first thing you see is a little lesion at the site of inoculation, and then lymphadenopathy develops proximal to the inoculation site. It's usually self-limited, so antibiotics aren't always necessary, but it can be treated with azithromycin. Bartonella can also cause bacillary angiomatosis, which presents as these small vascular lesions in immunocompromised patients. In AIDS patients, bacillary angiomatosis can be confused with Kaposi sarcoma. Next is Borrelia burgdorferi. And what does this cause? That's right, Lyme disease. It's transmitted from rodents to humans by the Ixodes scapularis tick. Okay, Borrelia recurrentis. This spirochete causes recurrent fever by varying its surface antigens. It's transmitted by ticks and lice and usually from a rodent. Now, Brucella species. These cause brucellosis, which usually presents as an acute febrile syndrome, often without many other localizing features. Contact with body fluids from infected animals like cattle, sheep, or goats, or consumption of unpasteurized dairy products can spread this infection. This is one potential risk of drinking unpasteurized milk. And there's another reason why pregnant women are told not to eat unpasteurized cheese or milk. Do you remember? Because of the presence of listeria in some of those products. Okay, Campylobacter. Campylobacter causes diarrhea and sometimes bloody diarrhea. Campylobacter is very common in birds as well as pigs. Meat can easily be contaminated with Campylobacter. Next is Chlamydophila psittaci, and this causes psittacosis, which presents with fever and dry cough. This is transmitted by birds like parrots, and it shows up on tests on a regular basis. So remember about psittacosis. Okay, Coxiella burnettii. This is the causative agent for Q fever, which presents with flu-like symptoms and abrupt fever that goes on for several weeks. This one can be transmitted to humans by aerosols from an infected placenta or from contaminated fluid on the coats of newborn farm animals. Ehrlichia chaffiensis. Ehrlichiosis usually presents with headache, muscle aches, and fatigue. It's transmitted by the Lone Star tick, usually from a white-tailed deer. Now, Francisella tularensis. This one causes tularemia. It can be transmitted directly from an infected animal, often a rabbit or a squirrel, or through a tick vector. Tularemia can present in a variety of ways, but the test question usually has a rabbit as the infected animal. Someone has found a dead rabbit, or they're hunting and skinning rabbits, something like that. One way that you can try to remember that rabbit tularemia association is by imagining a rabbit eating a tulip. Another thing you should be aware of is that this organism is considered high risk for use in bioterrorism. Leptospira. We just talked about this one a few minutes ago. This causes leptospirosis, and do you remember how this is transmitted? Remember that this one is transmitted through infected animal urine. Mycobacterium leprae. This is what causes leprosy. The 9-banded armadillo can carry this organism and appears to be the source of some cases of leprosy in the United States, though this does not appear to be the same route of transmission in other regions of the world. Okay, now Pasteurella multocida. Pasteurella is usually introduced into wounds from a cat or a dog bite. This can result in cellulitis and osteomyelitis. So if you see a question about a cat bite infection, definitely think of Pasteurella. All right, now let's talk about some rickettsia. Rickettsia prowazekii, Rickettsia rickettsiae, and Rickettsia typhi. Rickettsia prowazekii is the cause of epidemic typhus, and it's spread by lice. Now, Rickettsia typhi causes endemic typhus, also known as murine typhus. This is spread by fleas. We have some hot spots of murine typhus in Texas, and I end up seeing quite a few of these cases every summer. There's a couple of ways that you can try to remember these two organisms and separate them in your brain. It might help you to remember that there are two I's in prowazekii and an epidemic. And also the I sound in prowazekii sounds like the I sound in lice. Likewise, the E sound in typhi sounds like the E sound in fleas. The third rickettsia organism I mentioned, Rickettsia rickettsiae, is the causative organism for Rocky Mountain spotted fever. This is a tick-borne illness that can be fatal. It causes fever, headache, and rash. And remember that this is another rash that can be on the palms and the soles. And last but not least, Yersinia pestis. This one is famous for its association with bubonic plague, which is characterized by inflamed and painful lymph nodes called buboes. Of course, this caused huge problems in the 14th century, killing up to a third of the European population. And plague still occurs here in the United States, just on a smaller scale. It's still mostly spread by fleas, but one of the animal reservoirs in the US are prairie dogs. So beware of prairie dog infestations. Okay, now it's time for the end of session quiz. So I want you to turn off the video, answer your questions, and then turn back on your video so we can go through those answers together. All right, let's go through those questions now. What is the classic presenting symptom in a patient with Lyme disease? Remember, presenting symptom for the first phase would be erythema migrans, which is the expanding bullseye rash with a central clearing. What pupillary sign might point you to a diagnosis of syphilis? That's the Argyll-Robertson pupil, and this describes a pupil that is not reactive to direct light but constricts with accommodation. What organism is associated with each of the following clues? Lymphadenopathy plus a new kitten. That is Bartonella henselae, the organism that causes cat scratch disease. Dog bite. Pasteurella multocida. Now this pathogen is common in both dog bites and cat bites. Ixodes tick. Think Borrelia burgdorferi. Rabbit hunter. Francisella tularensis. Remember that if you see a rabbit on a test question, think of tularemia. And a pet prairie dog. In this case, Yersinia pestis is the correct answer, though I have no idea who would keep a pet prairie dog, really. So that's it for the end of session quiz, and that's it for our lecture on spirochetes and zoonotics. Now just a few rapid fire facts. Number 1, standard treatment for Treponema pallidum, penicillin. Number 2, cellulitis from a dog bite or a cat bite, Pasteurella multocida. 3, a non-painful, indurated, ulcerated genital lesion, chancre of primary syphilis. 4, moist, smooth, flat, white genital lesion, that would be condyloma lata of secondary syphilis. And large bullseye rash, and that's erythema migrans due to Lyme disease. And that is it for our lecture on spirochetes and zoonoses. I'll see you next time.
It's time for another warm-up. Let's get going. First question here, why should beta blockers never be used in cases of suspected cocaine intoxication? Well, beta blockers can actually lead to severe hypertension in patients who are using cocaine because of unopposed alpha-1 activation and blockade of that beta-2 vasodilation. Next, what is the embryologic origin of each of the following adult structures? So all these, the olfactory epithelium, the mammary glands, and the parotid glands, and the sweat glands, they all come from surface ectoderm. Next, what defects are seen in a patient with transposition of the great vessels? So you're going to get pulmonary trunk originates from the left ventricle, and the aorta originates from the right ventricle. All right, that's it for the warm-up. Let's get to that lecture.
In this video, we're going to discuss mycobacteria. So we're going to start with Mycobacterium tuberculosis. Now, we don't see a lot of TB in the U.S., but it's one of the most common causes of death worldwide, and about a third of the world's population has been infected with TB at one point in their lives. Mycobacteria are different than a lot of other bacteria. For one thing, they grow very slowly. They divide about once every 24 hours rather than once every 20 minutes like E. coli. So this means that growing mycobacteria in culture is a long-term commitment. The lab has to keep it for about 6 weeks. Another unique feature is that mycobacteria have mycolic acid in their cell envelope, which means that when you stain them, the stain is not removed by acidified alcohol. So these are commonly described as acid-fast bacilli, or AFB. Another characteristic of TB is that it has airborne transmission, meaning that we have to use negative pressure rooms and masks to protect ourselves and others from being exposed. So let's say that one of these bacteria escapes from the lungs of a person with active TB and then is inhaled by an uninfected person. If it gets down to the alveoli and establishes infection, that's called primary tuberculosis, which is usually marked by fever and possibly some pulmonary symptoms like cough. Most of the time, the chest x-ray is negative, but if it is abnormal, the most common findings are perihilar or right-sided infiltrates and ipsilateral hilar lymphadenopathy, so hilar lymphadenopathy on the same side as that primary infection. So that brings us to the Gone complex. When primary TB occurs, this may cause a lesion seen on chest x-ray called a Gone focus, where the primary infection occurred in the lung parenchyma. Now, when primary infection occurs, some of the TB will drain into the local lymphatic system, resulting in hilar lymphadenopathy that we see on chest x-ray. So when you have both the primary TB lesion, that Gone focus, plus the lymphadenopathy, we call that a Gone complex. So here you can see a Gone complex, which includes both the primary lung lesion, the Gone focus, plus the hilar lymphadenopathy. Now there are two possible outcomes of a primary TB infection. In about 90% of cases, the immune system fights the TB to a draw, basically, so that further bacterial replication is halted, and the infection kind of goes into a latent phase. So the bacteria are still there, just hanging out in the lymph nodes, and they're not really replicating. They're just kind of biding their time, waiting for more favorable conditions. Now, the other 10% of infected people cannot mount the appropriate immune response to control the TB, and they go on to have progressive infection. In this case, the TB may cause further local disease in the lung, or it can disseminate and cause miliary TB, where there are dozens of maybe even hundreds of these tiny, tiny TB foci scattered throughout the lungs or scattered throughout other organs. Or it can disseminate to the CNS and cause meningitis. Disseminated TB can infect almost any tissue and cause a variety of complications like bone and joint disease, gastrointestinal TB, and so on. But then think back to the 90% of people that do control that primary infection. Many of them remain asymptomatic and latent for the rest of their lives, but not all of them. In some of these individuals, the TB can eventually become reactivated. Remember we said that the bacteria were merely biding their time. Well, if the immune system becomes weakened by cancer or HIV infection or simply old age, there's an increased risk of developing reactivation TB. Now, reactivation can present with fever, night sweats, weight loss. If it's reactivating in the lungs, you may see cough and hemoptysis. So most of the classic TB symptoms are really associated more with reactivation TB than they are with primary TB. On chest x-ray, you'll frequently see infiltrates in the apical posterior segments of the upper lobes. Remember that, it's important. On your exam, something going on in the apices of the lungs is going to be a good clue for reactivation TB. TB that reactivates outside the lungs can show up really almost anywhere, kind of like we saw with initial progressive dissemination. TB can disseminate hematogenously during primary infection, so it can show up in the CNS, the bones, the GI tract, the GU tract, the peritoneum, the cardiovascular system, you name it, TB can be there. So patients with risk factors for TB exposure that present with prolonged fever or weird, difficult to diagnose clinical syndromes, think about TB as a possibility. Now, how do we diagnose TB? Well, it depends on what phase of TB infection you're trying to diagnose and where you suspect the infection is. In a patient who has chronic cough and hemoptysis and weight loss, you're going to be thinking about active TB infection of the lungs, right? So in this case, we look at the sputum. One relatively easy way to get a preliminary diagnosis is to catch sputum from a coughing patient and then look for the bacteria under the microscope. So you're going to request 3 sputum samples from a patient at least 8 hours apart. And early morning sputum samples are more likely to have bacteria, so at least one of those samples needs to be an early morning sputum specimen. Then the lab's going to perform an acid-fast stain on the sputum and see if they can identify any bacteria. And there need to be about 10,000 acid-fast bacilli per ml of sputum for us to be able to see the acid-fast bacilli this way. So it's not a very sensitive test. That's why we need to get 3 sputum samples. But even doing so, we still get a lot of false negatives. So in addition to looking at the sputum microscopically, we're also going to send each of these sputum samples for culture on Lowenstein-Jensen agar, even if the AFB smear is positive. So this is going to help us ensure that there actually are TB that we're looking at, not some other non-tuberculous mycobacteria, and it allows us to test for antibiotic sensitivity. Then a third diagnostic test, again to overcome the low sensitivity of the AFB smears and the long length of incubation for your culture, the third diagnostic test is to perform PCR testing on the sputum samples when we have a high index of suspicion. But this method is not terribly sensitive, and it's also fairly expensive. Well, that's well and good for pulmonary TB, but what about TB reactivation elsewhere, like in the CNS or the GI tract or the peritoneum? Well, in those cases, you need to get fluid or tissue samples from the involved site for staining and culture. And unfortunately, that can be time-consuming and invasive and fairly painful. Now, what if you suspect latent TB? So this is where we use the tuberculin skin test. So we inject purified protein derivative, or PPD, into the skin, to the inner aspect of the forearm, and then wait to see if it becomes indurated at 48 to 72 hours. And if the skin does become indurated, that indicates prior TB exposure, or possibly a current infection. Now, different patient risk groups are considered positive at different sizes of induration. And I don't think you're going to be expected to know this for step 1, but in the general population, they have to have 15 millimeters of induration at the site of the PPD to be considered positive. But over on the other end of the spectrum, in an HIV positive patient or somebody with immunosuppression for some other reason, or individuals with a known TB exposure, you're going to have a lower threshold for a positive test. So in those individuals, they're considered positive with just 5 millimeters of induration. And it's worth mentioning that one of the best known causes of a false positive PPD is vaccination with BCG, which is in the TB vaccine that's still given in some countries around the world. Now, another way to diagnose latent TB is called an interferon gamma release assay. 2 such tests are called quantiferon gold and T-spot. So these tests use a blood sample to see if the patient's T cells release interferon gamma in response to TB antigens. So one good thing about these interferon gamma release assays is that they're specific to TB and they don't cross-react with BCG. But the bad news about both the skin test and the interferon gamma release assays is that they can give false negatives, especially in people with suppressed immune systems like HIV patients, which unfortunately are often the people you want to screen, so it can be very frustrating. Once we've made the diagnosis of tuberculosis, how do we treat it? Now, we're only going to cover the standard treatment regimens here, although in practice it can become quite complicated. In a patient with latent TB, with no evidence of active disease right now, but who has risk factors for developing active disease, we treat with isoniazid alone for 9 months. Now, there are other possible regimens, but that's the preferred approach. But if the patient has active tuberculosis, the standard treatment includes 4 drugs for the first 2 months and then 2 drugs for the next 4 months. So you give 2 months of rifampin, isoniazid, pyrazinamide, and ethambutol, followed by 4 months of isoniazid and rifampin for a total 6-month course. And note that the first letters of these 4 initial drugs spell RIPE: rifampin, isoniazid, pyrazinamide, and ethambutol. Next, let's review the mechanisms of action and especially the side effects associated with each of these drugs, which can be significant. Let's start with rifampin. Rifampin is classified as a rifamycin, which includes rifampin, rifabutin, and rifapentine. Now, any of these drugs could be used in place of rifampin in treating TB for various reasons, which we're going to go over in a minute. But rifampin is by far the most common one of these that's used. Now, you can remember most of what you need to know about rifampin for step 1 by remembering the 4 R's of rifampin. The first R is the mechanism of action. Rifampin is an RNA polymerase inhibitor. Then the second R, rifampin revs up cytochrome P450. It induces P450 enzymes. Now, do you remember the mnemonic for all the P450 inducers? I'll give you a hint. Rifampin was the R in PBRs. Go back and review that if you need to. Now, because rifampin revs up P450, it can cause a lot of drug-drug interactions. Rifampin leads to lower plasma concentrations of things like warfarin, oral contraceptives, statins, levothyroxine, beta blockers, and especially some of the antiretroviral drugs used to treat HIV infection. So there are tons of important drug-drug interactions. Now, rifabutin does not rev up cytochrome P450 as much as rifampin does. So one use of rifabutin is treating TB in HIV patients who are taking antiretrovirals. Then the third R is for red. Rifampin causes body fluids like sweat and tears and urine and saliva to turn sort of a reddish-orange color. All the rifamycin can do this to a certain extent. It kind of freaks people out if you don't forewarn them. And it can also stain their clothes or stain their contact lenses. So one way you might be tested on this is a patient who has some indication for taking rifampin, and then they come in complaining of red tears or red urine, or they may say they have blood in their urine, but the dipstick is negative for blood and there are no red cells in the urine. And then the question is going to ask you what drug might cause this. Think about rifampin. Then the last R is for rapid resistance. We don't really use rifampin by itself most of the time because bacteria become resistant to it fairly rapidly if you use it alone. Then one other side effect to be aware of is hepatotoxicity, which is fairly rare. But unfortunately, hepatotoxicity is more common when you're taking rifampin along with other hepatotoxic drugs, such as isoniazid. So you do need to watch out for hepatotoxicity when you're treating somebody for TB. Now, besides TB, we sometimes use rifampin as prophylaxis in close contacts of patients with meningitis from Neisseria meningitidis or Haemophilus influenza type B. And it also has activity against MRSA, so that's another potential use. Now, we talked about using rifabutin instead of rifampin in HIV patients to avoid drug-drug interactions with antiretrovirals. And then rifapentine's claim to fame is that it has a longer half-life than rifampin does. So you can get away with once-a-week dosing, which is good for patients who aren't really reliable about taking their medications. And if you need to observe them taking each dose of medication with rifapentine, you only have to do that once a week. The next antimycobacterial drug in the RIPE regimen was isoniazid, or INH. Now, isoniazid inhibits the synthesis of mycolic acids, which are found in the mycobacterial cell envelope. Now, I mentioned that isoniazid causes some hepatotoxicity. It's common to see mildly elevated LFTs, and in severe cases, it can cause full-blown hepatitis. Isoniazid is also associated with peripheral neuropathy, and we give pyridoxine supplements to patients taking isoniazid to prevent this. So really, we always talk about a 4-drug initial regimen for TB. It's really a 5-drug regimen because all these patients need pyridoxine, which is vitamin B6. So if you think back to Farm Basics, we mentioned that vitamin B6 is a cofactor for some of the enzymes involved in the synthesis of neurotransmitters like acetylcholine and norepinephrine. Well, isoniazid competes with B6 in those enzymes, so it inhibits neurotransmitter synthesis and causes some neuropathy. So we're going to give vitamin B6 supplements to overcome that. Now, another potential adverse effect of isoniazid is drug-induced lupus, although that's much lower yield for your exam. Definitely remember hepatotoxicity and peripheral neuropathy, and then the B6 supplement to prevent that peripheral neuropathy. Now, our next drug is pyrazinamide. Its mechanism of action isn't clearly understood, but it's used as part of this initial treatment regimen for active TB. Then the adverse effects that you need to remember include hepatotoxicity again and hyperuricemia. Now, the hyperuricemia is usually asymptomatic, although it can lead to some flares of gout. But the hepatotoxicity is important because you're loading up the body with not just one, not two, but now 3 hepatotoxins in combination. The last drug is ethambutol. Now, its mechanism of action is also poorly understood, but it appears to block an enzyme called arabinosyl transferase, which leads to decreased polymerization of the sugar arabinose into arabinogalactan, which is a major part of the mycobacterial cell wall. I don't really think that mechanism is particularly important for this test. But what you should know is that ethambutol causes optic neuropathy, which can present as red-green color blindness or decreased visual acuity. And fortunately, this is usually reversible by simply stopping the ethambutol. Let's move on from Mycobacterium tuberculosis to some other species of Mycobacterium that you might see on your exam. First up, there's Mycobacterium avium intracellulare, or MAI. You may also see this referred to as Mycobacterium avium complex, or MAC. This can cause a pulmonary syndrome that's similar to TB, and then in immunosuppressed patients, like patients with AIDS, MAC can disseminate. Now, symptoms in these cases depend on where the mycobacterium has spread. For instance, if MAC goes to the GI tract, the patient might have abdominal pain and diarrhea. If it's in the bone marrow, the patient may have anemia and neutropenia. But MAI is such a problem in HIV patients that we give antibiotic prophylaxis. And there are 2 points you need to know about MAI prophylaxis. The drug we give is azithromycin, given once weekly. And we begin prophylaxis when the CD4 count falls below 50. Now, not every patient with HIV infection has AIDS, but when the CD4 count is below 200, that's definitely considered AIDS. So in an AIDS patient with a CD4 count below 50, you give azithromycin once weekly to prevent MAI. Another mycobacterial species to know is Mycobacterium kansasii. So this causes a pulmonary syndrome almost exactly like TB. The symptoms and X-ray findings are very similar to what we see in TB. A third non-tuberculous mycobacteria to know is Mycobacterium marinum. So this species is a little bit different. It causes cutaneous disease. And as the name implies, you get this one from exposure to contaminated water. So Mycobacterium marinum can live in both fresh water or in salt water, and includes swimming pools and fish tanks. And then it enters the skin through wounds or small breaks in the skin. It's frequently called fish tank granuloma because so many people get this infection from fish tanks. Our last mycobacterium is Mycobacterium leprae, which causes Hansen's disease, or the old-fashioned name is leprosy. So this mycobacterium likes to infect the peripheral nerves and the skin. Now, leprosy exists as a spectrum of disease, with lepromatous disease on one end and tuberculoid disease on the other end. So lepromatous disease occurs when there's a weak immune system to the mycobacteria, and the skin lesions have a lot of mycobacteria organisms in them. So these patients often have diffuse and disfiguring disease like you see here. Tuberculoid disease occurs when there's a strong immune response to the infection, and the lesions have very few mycobacteria present. So these people have relatively few skin lesions, which tend to be a little hypopigmented or erythematous instead of being so disfiguring. And they also have loss of sensation in the affected skin. These patients are sometimes difficult to identify because the findings are very subtle. And as I said, this is a spectrum of disease with a lot of gray area in between. It isn't always perfectly clear cut. Now, in addition to the skin lesions, Mycobacterium leprae infects peripheral nerves, and this can result in enlarged peripheral nerves and peripheral neuropathy, especially early on. This neuropathy leads to loss of function and repeated trauma to these areas. Now, in the southern U.S., leprosy can be a zoonotic infection. It's transmitted by the 9-banded armadillo. In the less armadillo-inhabited parts of the world, it's spread person to person, possibly through respiratory secretions. So individuals with lepromatous disease are most likely to transmit it to somebody else, considering the lack of immune response and the heavy burden of mycobacteria that they carry in their body. Now, Mycobacterium leprae cannot be grown in culture, but it can be identified by PCR, so that's how you're going to make the diagnosis. And we treat leprosy with a multi-drug regimen like we use for most mycobacterial infections. For patients with tuberculoid disease, we give dapsone and rifampin for 12 months. For patients with lepromatous disease, we give dapsone plus rifampin plus clofazimine for a total of 24 months. And let me remind you a couple of quick things about dapsone. So we use it to treat Hansen disease. Now, where else do we use dapsone? Well, it's one of the second-line options for prophylaxis or treatment of pneumocystis jirovecii. And do you remember hearing about an interesting adverse effect of dapsone? Well, dapsone is one of the drugs that causes hemolysis in patients with G6PD deficiency. There's one other drug we've mentioned in this video that also causes hemolysis in these patients. Do you remember what that was? It's isoniazid. So both dapsone and isoniazid are drugs used to treat mycobacterial infections that cause hemolysis in patients with G6PD deficiency. And that's it for Hansen disease. And on that note, let's bop on over to the study guide and work through the end of session quiz. First question, what's the distinction between a GON complex and a GON focus? And are these seen in primary TB or reactivation TB? So a GON focus is a lung lesion from primary TB infection, and then a GON complex is where you have a primary TB lung lesion plus hilar lymphadenopathy. So you can have a GON focus by itself, but if you have a GON focus plus lymphadenopathy, that's called a GON complex. And again, both of these are seen with primary tuberculosis. Next, what does a positive PPD skin test indicate? Well, it usually indicates true TB infection, either active or latent, but it can also indicate a history of BCG vaccination or infection with a non-tuberculous mycobacterium. So leprosy or MAI will also give you a positive PPD. Then the next question says, what does a negative PPD indicate? Well, these could be either true negatives or false negatives. So true negatives would be all the people that did not have TB at all. But you could also see false negatives in patients who did have TB but were on immunosuppressive medications like steroids, or perhaps patients who are immunocompromised from HIV or AIDS or cancer or advanced age. Or there could be technical difficulties with placing the PPD. Maybe they didn't inject enough or they stored it at the wrong temperature, something like that. The last question. A patient's attempting to recall for you what medications he's taking, and there's one medication he's taking to keep his lungs healthy that he also says can hurt his nerves unless he takes his B vitamin. So to what medication is he referring? Well, the most likely medication would be isoniazid, which he'd be taking to treat latent TB. And because isoniazid can cause neurotoxicity, he should continue to take his B6, which is pyridoxine. Now let's look at these rapid-fire facts. So associated with a GON focus or GON complex, again that's primary TB. Associated with lung infiltrate in the apical posterior segments of the upper lobes, that's reactivation TB. Then the standard initial treatment regimen for TB is RIPE, rifampin, isoniazid, pyrazinamide, and ethambutol. That's it for now. I'll see you next time.
Let's go over the warm-up. First question. A defect in the expression of the FMR1 gene is associated with what disorder? That's Fragile X syndrome. And the last question. What's the antidote for each of the following substances? So the treatment for iron toxicity is deferoxamine, which is an iron chelator. The antidote for lead poisoning include EDTA or Succimer or dimercaprol. The antidotes for cyanide toxicity are nitrites, hydroxycobalamin, or thiosulfate. The reversal agent for methemoglobin is methylene blue. For carbon monoxide poisoning, remember carbon monoxide binds to hemoglobin, and that competes with oxygen for the binding sites on hemoglobin. So the treatment is 100% oxygen and hyperbaric oxygen. And then for methanol or ethylene glycol poisoning, the drug of choice is fomepizole, which inhibits alcohol dehydrogenase. Or you could give ethanol, or you can do hemodialysis. Now let's move on to the lecture.
Hi, I'm Dr. Shuford. Welcome to our session on non-staining and poorly staining bacteria. Let's jump right in with Gardnerella vaginalis. Now, Gardnerella vaginalis is a big player in bacterial vaginosis. What's bacterial vaginosis? It's a very common cause of vaginal discharge. What appears to happen is that the bacterial flora of the vagina changes. The lactobacillus numbers decrease and other bacteria increase, especially gram-negative rods. It's not called bacterial vaginitis because there isn't inflammation or invasion of the vaginal epithelium. It's just really a shift in bacterial flora. But this shift in bacterial flora definitely makes itself known, usually as grayish vaginal discharge with a fishy odor. Now, there's also an associated elevation of vaginal pH to greater than 4.5. And one diagnostic clue to bacterial vaginosis is the clue cell. What's a clue cell? It's actually just a vaginal epithelial cell that's covered with coccobacilli. But there are usually a lot of them in bacterial vaginosis. Risk factors for bacterial vaginosis include new sexual partners or multiple sexual partners, How do we treat this? Usually with a 7-day course of oral metronidazole or with a course of metronidazole cream. Okay, enough about fishy discharge. Let's move on to Rickettsia. Rickettsia don't gram stain well, but they can be seen with Giemsa stain. Now, we mentioned rickettsial infections in another session, but we're going to review them again here. Remember that these illnesses are characterized by the rickettsial triad: headache, fever, and rash. This is especially true on tests. In real life, that rash can be hit or miss, but the fever and the headache are major clues to this diagnosis. These patients are suffering with headache and fever. The other thing that you must pop into your brain when you think of rickettsial illness is doxycycline. Doxycycline is the miracle pathway to get these people feeling human again. Now let's talk about a few rickettsial illnesses, starting with Rickettsia rickettsiae. Rocky Mountain spotted fever is what's caused by Rickettsia rickettsiae. This is transmitted by ticks. What are the symptoms? Rocky Mountain spotted fever has fever, headache, and rash, like the other rickettsial illnesses that we're talking to you about. But there is one thing I really want you to remember about Rocky Mountain spotted fever: rash on the palms and the soles. If you take a look at this image, you can see the rash. It usually starts on the wrists and ankles and moves to the palms, soles, and trunk. What other things cause rash on the palms and soles? So Kawasaki disease, Coxsackie-A, Rocky Mountain spotted fever, and secondary syphilis. Now, Neisseria meningitidis could also be included on this list, as meningococcemia can certainly cause a palmar rash, but is less common than these other causes that are seen in the Kawasaki CARS mnemonic. Okay, back to Rocky Mountain spotted fever. This infection is found in every state in the United States, utilizing different ticks in different regions, but it always has a tick vector. What about some of our other rickettsial diseases? Let's start with epidemic typhus. Remember that we're talking about Rickettsia prowazekii here. How is Rickettsia prowazekii spread? Through lice, head and body lice. Remember that we said that prowazekii, that long I, sounds like the long I in lice. Epidemic typhus has the same triad of headache, fever, and rash, but the rash starts centrally and then travels to the extremities, but it still spares the palms and the soles. You're not going to see it there. Now, endemic typhus, which is also called murine typhus, is caused by Rickettsia typhi. Remember that we said that E sound in typhi sounds like the long E sound in fleas. Rickettsia typhi is spread by fleas. Again, this is associated with that triad of headache, fever, and rash, where the rash starts centrally and then it spreads peripherally, but it spares the palms and the soles. Okay, now on to our next poorly staining bacterium, and that's Ehrlichia. Now, Ehrlichia chaffiensis causes human monocytic ehrlichiosis, or HME, and Anaplasma phagocytophilum causes human granulocytic anaplasmosis, or HGA. Now, just a few years ago, these were both called Ehrlichia because they're very similar organisms with usually indistinguishable clinical syndromes. They present with an acute febrile syndrome with nonspecific symptoms like headache, myalgias, chills. There can be some impressive lab abnormalities, but it's really hard to differentiate from some other illnesses, and it's hard to get a good diagnosis on this one as well. Culturing these organisms is nearly impossible. So one way to diagnose these infections is by looking for morulae, or inclusions within the monocytes or the granulocytes. These two organisms are both spread by tick vectors. Ehrlichia chaffiensis is usually spread by Lone Star tick, whereas Anaplasma is usually spread by Ixodes scapularis. Now, where have we heard about Ixodes scapularis before? Do you remember? Remember that this is the vector for Lyme. So this can get all confusing when someone living in Lyme territory is bitten by a tick and then ends up with a febrile illness. And actually, co-infection is not uncommon. The good news is that this whole situation can be cured with doxycycline. It is what we use to treat Lyme, and it is the treatment of choice for anaplasmosis. Doxycycline is the ticket here, and what would we do without doxy? Okay, let's move along to Q fever. The Q is for query, like, wonder what's going on with this patient. Q fever is a little bit strange. It's caused by Coxiella burnettii, which used to be considered a rickettsial organism, but it's not considered that anymore. But like Rickettsia, it's a small bacillus that doesn't stain well or culture well. One interesting thing about Coxiella burnettii is that it can go through a sporulation-like process that protects the organism and allows it to survive for a long time in the external environment. The primary sources of human Q fever are farm animals like sheep and cattle. It can be spread through aerosols from urine and feces. So working on a farm or even living downwind from a farm is a risk factor for Q fever. The placenta from an infected organism, from an infected animal, is going to have a very, very high burden of organisms. So birthing farm animals is actually a really big risk factor. Drinking unpasteurized milk is another risk factor. Now, we talked about another organism being spread through unpasteurized milk. Do you remember what that one was? We talked about brucella doing that as well. Now, Q fever presents as an acute flu-like illness, often with pneumonia, but then it can become a chronic illness that can be associated with endocarditis. Okay, now let's move on to chlamydia. Chlamydia trachomatis is a small intracellular rod-shaped organism that stains and cultures poorly, like everything else we've been talking about. Now, there are different serotypes of chlamydia trachomatis. Serotypes A through C cause trachoma, which is an acute eye infection that's mostly seen in resource-limited regions. The acute infection can lead to chronic scarring of the eyelid and to chronic corneal damage and eventually to blindness. Now, serotypes D through K are responsible for the sexually transmitted disease that we call chlamydia. The most common clinical manifestations in adults include urethritis, cervicitis, and pelvic inflammatory disease. And it's actually the most common bacterial cause of cervicitis. And unfortunately, it doesn't just stay in the lower reproductive tract. Chlamydia can easily ascend through the reproductive tract and cause scarring in the fallopian tube. The scarring there, as well as the destruction of the cilia within those tubes, place these infected women at very high risk of tubal infertility and ectopic pregnancy. And chlamydia is a major cause of infertility around the world, unfortunately. One major problem with chlamydia is that infection in adults is subclinical in about 50 to 80% of people. They don't even recognize any symptoms of being infected, so they can't seek out treatment. The chlamydia is left to just silently progress and slowly destroy the reproductive system. And that's why we recommend screening for chlamydia. Treatment of uncomplicated chlamydia is fairly easy. It's a one-time dose of azithromycin. Really, the trick here is making that initial diagnosis. Chlamydia can also infect babies who are born to infected mothers, resulting in a conjunctivitis and in pneumonia in newborns. So the topical ointment that prophylactically given to most infants at birth can treat gonorrhea conjunctivitis, but it's not effective at treating chlamydia trachomatis conjunctivitis, and this needs to be treated with oral erythromycin or azithromycin. And lastly, serovars L1, L2, and L3 cause lymphogranuloma venereum. And this is a sexually transmitted infection too, but it presents with a genital ulcer followed by unilateral lymphadenopathy. The lymph nodes can present like buboes, and then they go on to rupture, and this is where you see the groove sign. These same serovars, L1, L2, and L3, can also cause a very painful proctitis, which can be confused with inflammatory bowel disease, like ulcerative colitis or Crohn's disease. Now, don't confuse lymphogranuloma venereum with granuloma inguinale, which is caused by Klebsiella granulomatis and causes granulomas rather than that lymphadenitis. Another thing to remember about chlamydia trachomatis is that it's associated with reactive arthritis. Do you remember what other bacteria are associated with reactive arthritis that we've already mentioned in previous sessions? Well, diarrhea bugs are commonly associated with reactive arthritis, like Campylobacter, Yersinia, Shigella, and Salmonella. Okay, now let's move on to a couple of Chlamydophila species. These were formerly included in chlamydia species, but now are called Chlamydophila. The two that I'm going to highlight here both cause pneumonia. The first one is Chlamydophila psittaci, and this one is unusual because it's spread from a bird. It causes a pneumonia syndrome called psittacosis. Many bird species can actually serve as reservoirs for this bacteria, but test questions are usually going to include a statement about having a pet parrot at home. The other Chlamydophila species that we're going to mention here is Chlamydophila pneumoniae. Chlamydophila pneumoniae is a major cause of atypical pneumonia. The three primary etiologies of atypical pneumonia include Legionella pneumophila, Chlamydophila pneumoniae, and the one that we haven't talked about yet, Mycoplasma pneumoniae. Chlamydophila pneumoniae can cause a prolonged mild pneumonia, commonly called walking pneumonia. When it's diagnosed as Chlamydophila pneumoniae, the treatment of choice is doxycycline. But if no microbiological diagnosis is made, then the empiric treatment for atypical pneumonia is usually azithromycin, and it does work. Okay, let's finish up this session with Mycoplasma pneumoniae. This is a 4-star topic, so listen up while we talk about this one. Why is Mycoplasma one of the poorly staining bacteria that we're talking about today? Well, Mycoplasma species don't have a cell wall, so they're not able to be seen with gram stain at all. It's spread person to person through respiratory droplets. Mycoplasma is a very common cause of pneumonia in school-aged kids, in college students, and in military recruits. This is very similar to what we said about meningococcal meningitis. Now, test questions about Mycoplasma or Neisseria meningitidis frequently include a patient who's a college student, so look for that clue. Now, the first symptoms of Mycoplasma pneumoniae include malaise, headache, and low-grade fever, followed by a non-productive cough and diffuse interstitial infiltrates. This isn't the same picture that we see with typical pneumococcal pneumonia, where there's a really ill-looking patient, possibly looking a little septic, with a productive cough and a lobar infiltrate on chest x-ray. This is another of those walking pneumonias where a young person has been coughing for weeks and says that his head hurts terribly every time he coughs, but that he's actually making it through classes and doing okay. Now, chest x-ray will usually show patchy or reticulonodular infiltrates. So how do we diagnose this one? Well, actually, we don't often go after a specific microbiological diagnosis because empiric treatment for atypical pneumonia is usually successful when you use a macrolide like azithromycin or doxycycline, and fluoroquinolones can also be used. But if you are searching for a microbiological diagnosis, there are a few tests that you can use. And the one I want you to remember for the test is cold agglutinins. What are cold agglutinins? They are nonspecific IgM antibodies to erythrocytes that can occur early in this Mycoplasma illness. They can agglutinate or lyse red blood cells in cold environments, and that's why they're called cold agglutinins. Now, this response is nonspecific, though. Diagnosis can be made more definitively using either serology or PCR. Before we get to the end of session quiz, let's take a minute and do an exercise. There is a list of some buzzwords and descriptions on the left, and I want you to match it with the associated organism or condition on the right. So take a minute and jot down the answers, and then we'll go through them. Clue cells, fishy discharge, change in bacterial flora, that's Gardnerella vaginalis. Rash on the palms and soles, spread by ticks. Fever, headache. That's Rocky Mountain spotted fever. Central rash and spreads outward, spread by fleas, fever, headache. That's Rickettsia typhi. Urethritis, ectopic pregnancy, infertility. That's Chlamydia trachomatis. College student, prolonged cough, reticulonodular infiltrate. That's Mycoplasma pneumoniae. Exposure to sheep placenta, fever and pneumonia, endocarditis. That's Q fever, caused by Coxiella burnettii. And now let's go to our end of session quiz on non-staining bacteria. So go ahead, turn off your video, do the end of session quiz questions, and then start that video back up again so we can go through those answers together. All right, let's go through the answers to your end of session quiz. The first question, what is the rickettsial triad of symptoms? Remember, headache, fever, and rash. Really important, headache, fever, and rash. Next, a 25-year-old with Mycoplasma atypical pneumonia exhibits anemia due to cold agglutinins. What type of immunoglobulin is responsible for the anemia? Remember that cold agglutinins or cryoagglutinins are typically IgM antibodies. And lastly, what antibiotic should be used to treat each of the following infections? From Mycoplasma pneumoniae, just like with chlamydia infections, you're going to use doxycycline or a macrolide like erythromycin or azithromycin. For Rocky Mountain spotted fever, doxycycline. And bacterial vaginosis, it's treated with metronidazole. And that's the end of our end of session quiz, and that's the end of our lecture on non-staining bacteria. I'll see you next time.
Chlamydophila pneumoniae causes atypical pneumonia, which is symptomatically less typical than typical pneumonia. Atypical pneumonia is sometimes called walking pneumonia, although you don't catch it from walking, but you can have it while walking. You don't catch psittacosis from sitting down. You catch it from birds like parrots and parakeets. Psittacosis is a lung infection caused by Chlamydophila psittaci. Symptoms include fever, headache, and cough. The bird might be asymptomatic. Also, birds can't technically cough. Look it up.